Arturo Rubén Vergara, por si alguno todavía no me conoce. Quisiera, en primer lugar, dar a todos ustedes la bienvenida a que es nuestro primer simposio organizado por la cardiología de nuestro grupo, capitaneada por Joan, y que ha sido posible gracias al generoso sostén de la familia de Juaneda Hospitales, de la dirigencia, aquí representada por nuestro presidente, el doctor Joan Alguersuari, por nuestra gerente de Hospital Miramar, la licenciada Catalina Cervera, a quienes estamos obviamente muy agradecidos. Y obviamente el apoyo de Loli, que ha sido nuestra madrina en todo esto. Este encuentro está orientado en la cardiología, pero ha sido un nexo, o intenta hacerlo, para profesionales de muchas especialidades que hoy tenemos la suerte de tener aquí, a los cuales agradecemos de haber venido, especialmente cardiólogos intervencionistas, cardiólogos clínicos, médicos internistas, generalistas, nefrólogos, un poco porque, aunque el tema nace de la cardiología, una parte importante de los pacientes que nos toca tratar están afectados por otros órganos y sistemas. Entonces, la idea era hacer algo que no tiene que ser para nada un encuentro formal, mientras más coloquial y participativo sea mejor, y en el cual podamos debatir los temas que en este momento probablemente más nos interesan relativo a la asistencia de nuestros pacientes. Al respecto, leyendo lo que es las publicaciones de la Sociedad Española de Cardiología de los últimos 3 años, en España se hacen más de 75.000 angioplastias por año con implantes de stents. Y han aumentado un 15% en modo sostenido en los últimos 3 años. Ha perdido un poco la estadística del año 2020 por la epidemia, pero eso muestra un número importante. Son casi 1.600 procedimientos por millón de habitantes. Y es más o menos la media europea también. Entre ellos, hay que decir que en los registros europeos, porque no se pueden hacer estudios randomizados para ver cuántas enfermedades tienen los pacientes, pero sobre los registros europeos se puede decir en Europa que el 40% de los pacientes tratados con angioplastia tienen enfermedades de otros órganos y sistemas. Por eso, de nuevo, esta voluntad de crear un ambiente de diálogo nos pasa seguido con los colegas de la terapia intensiva, o generalistas o internistas. Mira, está este paciente que está en tratamiento con antiagregantes porque ha hecho una angioplastia, ¿cómo tendríamos que comportarnos? Y bueno, ahí está el asunto. Este argumento ha ido cambiando, mejorando y progresando rápidamente en los últimos 10 años. Especialmente en el último periodo. Probablemente no porque nacen nuevas moléculas, pero sí cambian las estrategias. Entonces, algo que parecía muy claro en un sentido, de un momento al otro cambia hasta en un sentido opuesto. Entonces nuestros colegas nos dicen, pero ¿cómo? No había que conducir en este sentido y ahora vamos en el opuesto. Bueno, a eso sirve mantenernos actualizados, en definitiva. Y es por eso que hemos elegido el tema del tratamiento en los pacientes que han recibido una angioplastia con implante de stent. Y por eso agradecemos aquí a nuestros 4 exponentes de hoy, Joan, Ángela, Renato, Marco, que han hecho el esfuerzo de venir hasta aquí para compartir con nosotros sobre este tema y poder discutir las novedades en este sector. Sobre el recorrido que haremos alrededor del simposio, primero empezará Joan con la difícil tarea de tener que contarnos cuáles son los criterios que identifican a los pacientes de más alto riesgo, siendo que los tratamientos que damos especialmente afectan, por ejemplo, la coagulación de los pacientes, los más ancianos y los predispuestos a hemorragias son probablemente los más delicados. No es fácil, como decíamos con Joan, porque es un territorio en el cual no hay estudios que vayan directamente a ver esta cosa, por eso Juan lo ha aceptado. Después sigue Renato, que es un experimentado operador en Italia, para contarnos en un modo que pueda ser claramente lo más llano posible cuáles son las novedades en el tratamiento en agudo, es decir, cuando el paciente tiene el infarto, tiene que recibir una angioplastia y se encuentra en la sala operatoria. Esas cosas van cambiando también. Después sigue Ángela, es decir, sale el paciente de la intervención, Ángela nos ayudará a repasar lo que son los tratamientos en el mediano y largo plazo también, las elecciones, cómo han cambiado esto, cómo están cambiando. Y después tenemos la suerte de contar con Marco. Marco es muy joven, pero tiene mucha experiencia en estudios clínicos, es un investigador, digamos, de pura cepa, como decíamos, la punta de diamante probablemente la cardiología intervencionista mundial. A mi parecer, no es el único, creo que lo condividimos. Y Marcos nos dirá, sobre la base de los importantes estudios de los cuales él ha sido el protagonista principal, cuál es probablemente el futuro inmediato de lo que vamos a ver. Es decir, qué tendríamos que prepararnos en los próximos meses, porque esto está cambiando. Y al último, aunque parezca una cosa quizás demasiado especialística, como también el tratamiento del infarto presenta innovaciones, ahora ha resurgido una parte del tratamiento que es la del quitar el trombo, ¿no? La trombectomía. Bueno, el grupo donde yo trabajaba en Florencia tiene trabajos con trombectomía bastante importantes, pero bueno, no pudimos traducirlo eso en resultados clínicos, por eso no han cambiado. En cambio, Marco ahora nos muestra justo lo que va a ser la última frontera en el tratamiento del infarto, que es la trombectomía con retriever, con un método que es el stent retriever. Digamos, tratando de hacerlo también una cuestión que sea coloquial. Así que bueno, aquí me paro yo a darles la bienvenida de nuevo, agradecer vuestra presencia e invitar al primero de los ponentes. Seguramente Andrés me dará una mano. Andrés, como buen argentino, es muy bueno para expresarse. Así que, bueno, empezaremos presentando a Joan con el primer trabajo.
¿Qué tal? Buenas tardes a todos. Bueno, ya creo que redunda la presentación. A Joan Alguersuari lo conocemos todos, venimos trabajando hace años con él. Como dijo Rubén, agarra un territorio que es complejo, pues un territorio que tenemos poco número de pacientes, que tenemos poca evidencia y que tenemos que manejarnos muchas veces por intuición y no por evidencia. Nos va a hablar del paciente de alto riesgo hemorrágico y cómo identificarlo. Gracias.
Bueno, daros la bienvenida a todos. Y ¿no se oye este micro? Sí, sí. Bueno, y nada, agradecer a Rubén, pues, que ha sido el motor de la organización de este primer congreso, y a toda la gente de Juaneda que ha colaborado en organizarlo. La charla que me ha tocado hacer es la identificación del alto riesgo hemorrágico en pacientes que van a ser tratados con intervencionismo coronario percutáneo. Bueno, como sabéis, el síndrome coronario agudo, la fisiopatología del síndrome coronario agudo se caracteriza por una inestabilización de una placa arteriosclerótica en las coronarias, en las que cuando se produce la ruptura de la capa fibrosa se expone el contenido de la placa y eso es altamente trombogénico, de modo que se produce una activación plaquetaria que a su vez activa la cascada de la coagulación. El resultado es el trombo fibrinoplaquetario, que provoca una oclusión aguda y súbita de la arteria coronaria, provocando el síndrome coronario agudo. De ahí se deduce que el tratamiento médico del síndrome coronario agudo sea una combinación de fármacos que inhiban la agregación de las plaquetas, es decir, fármacos antiagregantes, y fármacos que inhiban la acción de la coagulación, es decir, fármacos anticoagulantes. La combinación de estos tratamientos lo llamaremos tratamiento antitrombótico. Esta es una diapositiva, esta es una imagen que he obtenido de las guías de síndrome coronario agudo sin elevación del ST de la Sociedad Europea de Cardiología, en la que vienen representados los fármacos antiagregantes y anticoagulantes que pueden estar implicados en el síndrome coronario agudo sin elevación del ST. En la parte de abajo tendríamos los fármacos antiagregantes, en la parte de arriba tendríamos los fármacos anticoagulantes. En negro tenemos los fármacos que se administran por vía oral, en rojo los fármacos que se administran por vía endovenosa. Pues fijaros qué gran cantidad de fármacos tenemos para actuar en diferentes puntos de la coagulación y que ello tenga un impacto en el síndrome coronario agudo, ¿no? Tenemos los antiagregantes orales de uso habitual, clopidogrel, parasubrel y ticagrelor, y los que se pueden utilizar por vía endovenosa, los inhibidores de la glicoproteína 2B3A, Y luego tenemos los fármacos anticoagulantes, que generalmente se dan por vía parenteral, como serían la heparina no fraccionada, la heparina de bajo peso molecular y el fondaparinux, o también la bivalirudina. Otros fármacos anticoagulantes que son orales no tienen indicación en el tratamiento del síndrome coronario agudo, pero a menudo están presentes en pacientes que tienen otras cardiopatías y que tenemos que tenerlos en cuenta a la hora de tratar a estos pacientes cuando tienen un síndrome coronario agudo. Y bien, es importante balancear entre el riesgo trombótico y el riesgo hemorrágico, ¿no? Si damos todos estos fármacos que os he enseñado de forma aleatoria, pues evidentemente estamos diluyendo la circulación y esto inevitablemente aumentará el riesgo hemorrágico. Y por tanto tenemos que balancear, equilibrar el riesgo entre trombosis y el riesgo de hemorragia, ¿no? Porque lo que es evidente es que no todos los pacientes que tienen un síndrome coronario agudo tienen el mismo riesgo trombótico. No es lo mismo un paciente que tiene un único episodio de dolor torácico, que no se acompaña de cambios en el electro y que no repite dolor durante el ingreso, ni eleva los marcadores de lesión miocárdica, pues esto no es lo mismo que un paciente que tiene dolor torácico con cambios en el electro, que se elevan las troponinas y que además repite dolor durante el ingreso a pesar del tratamiento correcto. O sea, el riesgo trombótico de estos dos pacientes, los dos tienen un síndrome coronario agudo. Pero el riesgo trombótico de este síndrome coronario agudo no es el mismo. Y por tanto, pues, puede haber diferencias a la hora de seleccionar el tratamiento antitrombótico. Y del mismo modo, no todos los pacientes tienen el mismo riesgo hemorrágico, ¿no? No es lo mismo un paciente de 50 años que no tiene ninguna patología previa que un paciente añoso que además tiene insuficiencia renal crónica y que a lo mejor está tomando un fármaco anticoagulante por una fibrilación auricular. En definitiva, lo que quiero mostraros con estos ejemplos es que no todos los pacientes los podemos tratar igual, ¿no? Y que tenemos que individualizarlos en función de si es mayor el riesgo trombótico o es mayor el riesgo hemorrágico. Bueno, y esta figura viene a representar esto, ¿no? Cuando hacemos el balance entre el riesgo trombótico y el riesgo hemorrágico, pues tenemos que tener en cuenta varios aspectos, ¿no? En primer lugar, pues tenemos que tener en cuenta las características clínicas del paciente, ¿no? Lo que decíamos, la edad, no es lo mismo un paciente de 50 años que un paciente de 80 años. El sexo, que como veremos más adelante, las mujeres tienen más riesgo de sangrado. Puede haber diferencias raciales también. Y evidentemente pues hay que tener en cuenta si el paciente tiene historia previa de sangrado. No es lo mismo un paciente que tiene historia de hemorragia digestiva previa que un paciente que no ha sangrado nunca, ¿no? También tenemos que tener en cuenta cómo se presenta el síndrome coronario. No es lo mismo un síndrome coronario agudo, que hemos visto que se caracteriza por una placa inestable con un trombo fibrinoplaquetario, que un síndrome coronario crónico, ¿no? Un paciente con una angina de esfuerzo estable, que generalmente es debida a una placa severa, pero no inestable, y que por tanto suele tener menos carga de trombo fibrinoplaquetario, pues quizá no hay que ser tan agresivos con el tratamiento antitrombótico, ¿no? Luego hay que tener en cuenta las comorbilidades del paciente, especialmente pues, la insuficiencia renal, pero otras comorbilidades como la diabetes o la insuficiencia cardíaca pues pueden tener impacto a la hora de valorar el riesgo trombótico y hemorrágico. En cuarto lugar, hay que tener presente otros tratamientos que puedan también favorecer el riesgo hemorrágico. Y aquí se refiere fundamentalmente a los pacientes que necesitan anticoagulación oral por otra patología diferente al síndrome coronario agudo, como sería la fibrilación auricular. Y por último, pues hay que valorar aspectos del procedimiento, ¿no? Estamos hablando de pacientes que en la mayoría de los casos van a ser sometidos a un cateterismo cardíaco, y por tanto pues hay que tener, no es el mismo riesgo hemorrágico si el procedimiento se hace por vía femoral o por vía radial. No es igual el riesgo hemorrágico si el paciente va a ser sometido a una angioplastia con stent que si va a ser operado de cirugía de bypass. y tampoco el riesgo hemorrágico es igual si se hace pues un intervencionismo o si el paciente pues no se le hace un cateterismo y se maneja simplemente con tratamiento médico, ¿no? En función de todas estas características, pues tenemos que seleccionar el tratamiento antitrombótico más adecuado para el paciente para obtener la máxima protección contra nuevos eventos trombóticos, minimizando el riesgo hemorrágico, ¿no? Este es el objetivo, ¿no? Encontrar un tratamiento que disminuya al máximo la probabilidad de que ese paciente tenga otro evento trombótico, pero sin que esto se traduzca en un mayor riesgo hemorrágico, ¿no? ¿Y cómo lo hacemos esto? Pues habrá que individualizar el tratamiento según el riesgo hemorrágico del paciente. Vale, ¿y por qué son importantes las hemorragias, ¿no? Porque dicen, bueno, pues si sangra, sangra, ¿no? Pues no, es importante el sangrado, ¿por qué? Porque el sangrado mayor se asocia a un aumento de mortalidad en pacientes que tienen un síndrome coronario agudo sin elevación del ST, y ese aumento de mortalidad tiene una proporción similar a la de tener un evento isquémico espontáneo, ¿no? ¿Y esto por qué es así? Bueno, es así porque la hemorragia por sí sola puede matar, ¿no? Una hemorragia digestiva grave, una hematuria grave, una hemorragia cerebral, si es grave, pues por sí sola te puede matar. Pero luego tiene otro riesgo, que es que cuando el paciente tiene un evento hemorrágico, a menudo te obliga a parar el tratamiento antitrombótico en parte o en su totalidad, ¿no? Y eso inmediatamente se traduce en un aumento de riesgo de volver a tener otro evento trombótico, sobre todo si al paciente ya se le han implantado stents, ¿no? Y es por eso que en estos pacientes pues, se recomienda estratificar el riesgo hemorrágico para decidir cuál es la estrategia antitrombótica más adecuada, ¿no? Además de valorar el riesgo hemorrágico en el momento de presentación del síndrome coronario agudo, también hay que reevaluarlo antes del alta, sobre todo de cara a decidir la duración de la doble terapia antiplaquetaria, ¿no? Estos pacientes, la mayoría de los casos, van a requerir 2 antiagregantes plaquetarios, pero como veremos en las siguientes presentaciones, pues la duración del tratamiento puede ser diferente según el riesgo hemorrágico o otras características del paciente. ¿Y cómo estratificamos el riesgo hemorrágico? Bueno, pues el riesgo hemorrágico se puede estratificar pues, de una forma cualitativa, que es con el método del ojímetro, ¿no? Pues mirar las 4 características clínicas que sepamos que hacen que ese paciente tenga mayor riesgo hemorrágico, pues como sería el que tenga una fibrilación auricular y esté tomando anticoagulantes, o el que haya tenido una hemorragia previa. Pero luego hay una manera más rigurosa, más fina de estimar el riesgo hemorrágico, que es utilizando los scores de riesgo. Y los scores de riesgo para estratificación del riesgo hemorrágico son estos de aquí, el Crusade y el Acuity, que tienen un valor predictivo razonable en pacientes que van a ser sometidos a cateterismo, aunque su valor predictivo no está bien establecido en pacientes que se tratan médicamente y que por tanto no se les hace un cateterismo, ni tampoco está bien establecido en pacientes que están tratados previamente con anticoagulantes orales. La recomendación de estratificar el riesgo hemorrágico está recogida en las guías de síndrome coronario agudo sin elevación del ST de la Sociedad Europea de Cardiología de 2020 y es una recomendación 2B con un grado de evidencia B. De los scores de riesgo, el más utilizado es el Crusade, que estima la probabilidad de que el paciente tenga un sangrado mayor durante un ingreso por un síndrome coronario agudo sin elevación del ST. Es el score que mejor estima el riesgo de sangrado intrahospitalario y otra bondad del Crusade es que los pacientes que tienen un Crusade score alto también tienen un mayor riesgo de sangrado mayor a largo plazo, cuando reciben doble terapia antiagregante prolongada. De ahí que el Crusade también puede ser útil a la hora de guiar la duración de la doble terapia antiagregante. Esta es la calculadora que podemos encontrar online para calcular el Crusade en un paciente cuando ingresa por un síndrome coronario agudo sin elevación del ST. En ella se recogen una serie de características clínicas como son la frecuencia cardíaca, la presión arterial sistólica, el hematocrito, el aclaramiento de creatinina, el sexo, los signos de insuficiencia cardíaca, historia de enfermedad vascular y la historia de diabetes. En función de estos ítems, pues obtienes un resultado que es la probabilidad de que ese paciente que se presenta con un síndrome coronario agudo sin elevación del ST presente un sangrado mayor durante el ingreso. Y fijaros si es importante clasificar el riesgo hemorrágico del paciente, que como veremos en otras charlas, y no quiero entrar mucho en detalle, en función del riesgo hemorrágico, si el riesgo hemorrágico es bajo, es alto o es muy alto, no solo podemos decidir un tratamiento antitrombótico diferente durante el ingreso, sino que determinará el tipo de tratamiento, el tipo de doble terapia agregante plaquetaria que vamos a utilizar y su duración, ¿no? Por tanto, esto es una prueba clara de la importancia de estimar el riesgo hemorrágico en estos pacientes que se presentan con un síndrome coronario agudo sin elevación del ST. Y para ilustrar un poquito pues la importancia del riesgo hemorrágico, he preparado un caso clínico que hemos tenido recientemente, en el que se pone de manifiesto pues la importancia del riesgo hemorrágico, ¿no? Os presento un paciente varón de 78 años con antecedentes de hipertensión arterial, dislipemia y diabetes tipo 2. También había tenido una tuberculosis en la infancia que no le había dejado secuelas y tenía hemorroides. Además tenía una anemia ferropénica que no se había estudiado en profundidad, que se atribuía a sus hemorroides, y hasta el ingreso actual, que fue en marzo, pues no tenía historia de cardiopatía previa. El paciente seguía tratamiento con antidiabéticos orales, con olmesartán como antihipertensivo, atorvastatina como hipolipemiante, omeprazol, y tomaba 2 comprimidos de hierro a la semana por esto de que tenía un poquito de anemia ferropénica. Pues bien, este paciente ingresó en marzo por una clínica de disnea progresiva hasta hacerse de pequeños esfuerzos, que además se acompañaba de opresión torácica de esfuerzo, bastante sugestiva de angina, que al detenerse desaparecía. El día del ingreso, esta opresión torácica apareció en reposo, fue más intensa y más prolongada, y por eso decidió consultar. Un dato muy importante, pero que el paciente no nos dijo cuando ingresó, es que llevaba 3 meses teniendo rectorragias. Él explicaba que tenía emisión de heces, con sangre, tanto de forma espontánea cuando iba al lavabo como cuando iba al lavabo como de forma espontánea. A veces manchaba la ropa interior. Pero esta información él no la dijo cuando ingresó, ¿no? Al ingreso el paciente estaba hemodinámicamente estable, un poco taquicárdico, a 120 por minuto, tenía una saturación del 95% y no tenía signos clínicos de insuficiencia cardíaca. Este es el electrocardiograma en el que se puede ver una fibrilación auricular a 120 por minuto, con bloqueo de rama derecha y sin claras alteraciones de repolarización, más allá de unas test negativas asimétricas en D1 y AVL. Esta es la radiografía de tórax, en la que se ve un poquito de congestión periliar y redistribución vascular. Y en la analítica el paciente tenía una hemoglobina de 9,3, un hematocrito del 28%, una creatinina de 1,3 con un filtrado glomerular de 52 mililitros minuto, y unos valores de NT-proBNP de más de 5.000 y una troponina I ultrasensible de casi 600, siendo el valor de normalidad inferior a 20. En el ecocardiograma tenía una hipertrofia ventricular ligera con una fracción de eyección del 39% y una insuficiencia mitral ligera moderada, una insuficiencia aórtica ligera, una insuficiencia tricuspidea moderada y una hipertensión arterial pulmonar moderada. Esta es la imagen del eco, en el que se aprecia pues esta disfunción ventricular con una fracción de eyección calculada en torno al 39%. Y este es el cálculo del crusade para este paciente, que nos salía un crusade del 21%. En teoría este sería el riesgo de sangrado mayor de este paciente durante el ingreso, aunque en realidad, pues ya sabiendo que venía sangrando desde hacía 3 meses, pues ya era ya se podía sospechar que las probabilidades de que sangrara serían más altas, ¿no? Bien, en UCI a este paciente se inició tratamiento con aspirina y con heparina de bajo peso molecular a dosis anticoagulantes, y se frenó la fibrilación auricular con betabloqueantes. A las pocas horas revertió espontáneamente a ritmo sinusal. Al día siguiente del ingreso se le hizo una coronariografía. En la coronariografía se objetivó enfermedad coronaria severa de 3 vasos, con afectación de descendente anterior proximal, que además tenía un flujo enlentecido TIMI2. Y en esos momentos, que recordad que en esos momentos no sabíamos, no había sangrado, ni sabíamos que hubiera sangrado recientemente, pues se recomendó revascularización coronaria quirúrgica. El paciente no tuvo complicaciones en la UCI y pasó a la planta pendiente de programar la intervención. Estas son las imágenes de la coronariografía. Aquí podemos ver la coronaria derecha con una lesión severa en el segmento medio, y esta es la coronaria izquierda, en la que se ve la descendente anterior con una lesión crítica y un flujo distal enlentecido, y no se ve también aquí la lesión de la circunfleja, que también tenía lesión severa en ese vaso. Bien, una vez el paciente me llegó a la planta, es cuando tuvo una rectorragia no mayor de la que venía presentando en los últimos 3 meses, pero fue el momento en el que nos manifestó pues, que tenía rectorragia y que las venía presentando desde hacía 3 meses. En ese momento mi decisión fue la de retirar la aspirina, pero le mantuve la anticoagulación con heparina de bajo peso molecular, pues porque tenía una fibrilación auricular paroxística y además había tenido un síndrome coronario agudo reciente, y no me parecía prudente retirarle por completo los fármacos antitrombóticos. Se organizó una colonoscopia en la que se puso de manifiesto un adenocarcinoma de recto. Y ahí, en ese momento pues, tuvimos la dificultad de qué había que tratar primero, porque con sangrado activo, hacerle cirugía de revascularización coronaria, corríamos el riesgo de que también tuviera hemorragia, un sangrado mayor. Y bueno, y lo que hicimos es pues hicimos una reunión de los cardiólogos y del Heart Team con el comité de tumores, y se decidió pues hacer primero un ciclo corto de radioterapia rectal, que ayudaría a estabilizar pues la hemorragia del tumor de recto. En segundo lugar, hacer cirugía coronaria. Con esto conseguíamos mejorar el pronóstico y los síntomas desde el punto de vista cardiológico, y otra cosa importante, que es reducir el riesgo de la cirugía oncológica, que se haría en último lugar, ¿no? Y bueno, y por último, una vez completadas estas 2 etapas, pues la idea pues sería hacerle la cirugía colorectal, ¿no? Entonces, en planta, previo al alta, yo decidí, como todo este proceso podía dilatarse, el proceso de que lo viera el oncólogo radioterapeuta, se le hiciera la radioterapia, no me atraía la idea de dejarlo con heparina de bajo peso molecular durante semanas, y tomé la decisión de cambiarle la heparina de bajo peso molecular por dabigatran, 110 miligramos cada 12 horas. La decisión de la selección de este fármaco fue porque había disponibilidad de antídotos si presentaba una hemorragia severa, y por lo que os comentaba de que no sabíamos el tiempo que se dilataría la radioterapia hasta que lo pudieran operar de cirugía coronaria. El paciente se dejó ingresado un tiempo prudencial para ver que el sangrado no empeorara, y durante el ingreso tuvo unas rectorragias parecidas a las que venía teniendo, pero sin repercusión sobre la hemoglobina, que de hecho incluso aumentó un poco en los controles que hicimos, ¿no? Y por eso pues, fue dado de alta con dabigatran, 110 miligramos cada 12 horas, sin aspirina. Se le recomendó vigilar las deposiciones, y también se le recomendó interrumpir el tratamiento si empeoraba la rectorragia. Pero a los 10 días el paciente pues, empeoró, aunque no había habido un sangrado más importante aparentemente, pues estaba con un síndrome anémico marcado y tenía angina de pequeños esfuerzos, Acudió a urgencias y tenía una hemoglobina de 5,9, un hematocrito de 18%, y bueno, se tuvo que ingresar, transfundirle 6 concentrados de hematíes y con eso mejoró. En ese momento pues se decidió retirarle todo el tratamiento antiagregante y anticoagulante, y el paciente estuvo sin tratamiento hasta que se le hizo la radioterapia, que se hizo más o menos a las 2 semanas. Se le pudo hacer un ciclo corto de 1 semana de radioterapia. Después de la radioterapia el sangrado rectal se estabilizó, y ahora hace 2 semanas o así le pudieron operar de cirugía coronaria. Le hicieron 2 bypasses aortocoronarios con una mamaria descendente anterior y una sacena descendente posterior. No se pudo revascularizar la circunfleja por mal vaso, y al alta pues también le fue dado de alta con el mismo tratamiento antitrombótico, y en este momento pues está en fase de recuperación de la cirugía coronaria para programar la cirugía colorectal, ¿no? Bueno, es un caso que ilustra pues a veces la dificultad de tomar decisiones respecto al tratamiento antitrombótico en nuestros pacientes, y que a toro pasado pues quizás hubiera tomado la decisión de no darle un anticoagulante de acción directa y dejarlo con heparino de bajo peso molecular, pero es que tampoco sabía el tiempo que se demoraría en hacer la radioterapia, y por eso le puse un anticoagulante de acción directa. Si hubiera sabido que en 2 semanas hubiera recibido la radioterapia, pues seguramente le hubiera dejado la heparina de bajo peso molecular. Bueno, como conclusiones de mi presentación, pues tenemos que recordar que es importante valorar el riesgo hemorrágico en pacientes sometidos a intervencionismo coronario percutáneo, especialmente en el contexto de un síndrome coronario agudo, porque hemos visto que eso tiene impacto sobre la mortalidad. Hemos visto que existen scores de riesgo para establecer el riesgo hemorrágico en estos pacientes con síndrome coronario agudo. El más usado es el Crusade, y es importante establecer el equilibrio entre el riesgo trombótico y hemorrágico, y individualizar cada tratamiento para cada paciente en función de este riesgo.
Gran presentación.
Gracias.
Es muy fácil. Estamos abiertos a las preguntas por si alguien quiere particularmente hacer una. ¿Qué tal? Yo más que nada quería demostrar aquí con lo que Joan ha presentado ahora, cuánto sea importante la conexión de especialidades, ¿no? Aquí se ve un paciente que tenía un doble problema, por otro lado son significativos del pronóstico de vida, y cuánto a veces nos cuesta encontrar un parámetro para seguir, para tratar de combinar las dos cosas. El paciente entra con un síndrome coronario agudo y comprometido, con difusión ventricular, pero también tenía un colon rectal, ¿no? Así que difícil, pero representativo. No sé si hay alguien que...
Una pregunta dándole práctica, ¿no? Como dijimos antes, estamos hablando de un tema que el gran defecto que tenemos es que son Ns bajos, son errores betas, y vamos a querer cualquier tipo de cálculo para tener una evidencia contundente. De hecho, los podía patinar, ¿no? Por de hecho se podía comer la parte de las hemorragias que él no nos había contado, etcétera. En otras patologías nos pasa que los scores terminan siendo más un sí no que una escalera, como pasa con el Hasbled, con el chat de Basque, ¿no? Que sabemos que termina siendo que si cumple este punto ya pasa del otro lado. Si tuvieras que definir un punto que es el que a ti te define más que nada, en cuál paciente va a decir cuidado que este tiene mucho más riesgo hemorrágico desde el punto de vista de tu experiencia clínica, ¿cuál dirías? ¿Cuál buscarías como punto de decir si lo tiene este paciente, cuidado?
Bueno, yo creo que es lo que nos marca mucho a la hora de decir el tratamiento antitrombótico es la hemorragia previa, sin duda. La necesidad de tener que tomar tratamiento anticoagulante tiene un impacto clarísimo a la hora de decidir el tratamiento antiagregante, pero luego hay que tener muy presente la insuficiencia renal también, ¿no? Los pacientes con insuficiencia renal sangran más, ¿no? Y a veces es difícil ajustar todos estos fármacos en función del filtrado glomerular. Por tanto, Bueno, son muchos aspectos que hay que tener en cuenta, pero que quizás los que más te marcan son los que te he comentado: la hemorragia previa, la necesidad de tomar anticoagulantes por otras patologías y la insuficiencia renal.
Así, Joan, es un caso muy, muy interesante, muy paradigmático de lo que es el mundo real, ¿no?, de alguna manera. Hay una cosa que me llama la atención y que te quería preguntar. En el score que hacemos o que haces con el Crusade está la cifra de tensión sistólica en el momento en que tú ves el paciente, pero no están los antecedentes de hipertensión. Y me pregunto si de alguna manera es una cosa lleva a la otra, o si los antecedentes de hipertensión, independientemente del hecho que el paciente en ese momento está a 110 o esté a 140, pueda tener también un valor de mayor riesgo de hemorragia.
Yo entiendo que los ítems que se recogen en el Crusade son aquellos que se han visto que tienen correlación con el riesgo hemorrágico, ¿no? En los estudios que se han hecho en estos pacientes, pero no lo sé exactamente. No sé por qué se tiene en cuenta la presión arterial al ingreso y no el antecedente de hipertensión. Supongo porque se ha visto que el antecedente de hipertensión no tiene impacto en el riesgo hemorrágico y en cambio las cifras de presión arterial sí. Pero sinceramente no sé, o sea, no te puedo decir la evidencia en la que se basan cada uno de los ítems del Crusade, no, la desconozco.
Llevamos al... Si no, pega.
Gracias, Rubén. No, el caso parece, es más complejo de lo que parece. La decisión no fue tan fácil porque estamos enfrente de un evento coronario agudo, de alto riesgo, con lesiones críticas, y la idea era revascularizar lo antes posible, ¿no? El tema es cuando vemos el paciente tiene una caquexia, pesa 55 kilos, todo esto viene después, es un paciente extranjero, la información siempre es más diluida, no tiene familia cercana, la mujer viene a verlo cada 3 días, el paciente ha perdido 35 kilos en 3 meses o 25 kilos y te encuentras un paciente frágil. Entonces dijimos, vamos a esperar un poquito a acabar el estudio de extensión de un posible tumor el contexto de la escasez fue en contexto de una anemia de una hemoglobina de 7 y pico, si no me equivoco, cayó la hemoglobina 7 y medio. Y en la espera del estudio y tal, el paciente se estabilizó un poquito y también dudamos si no operarlo. Yo creo que también se hubiera podido operar, aunque sí ese riesgo hemorrágico existe, pero se hubiera podido operar, pero balancear si un sangrado durante la cirugía o no. Pero el paciente se estabilizó y después descubrimos también que tiene una angina ya de meses de evolución, una fatiga, no sabemos si por la anemia, si por la enfermedad coronaria subyacente, y al final hizo la terapia bastante rápido y también con eso superó con una hemoglobina de 7,8.
De 7,8.
Sí. Y la verdad que limitamos un poco los bypasses porque el paciente se hipotensó bastante durante el inicio de la cirugía, hizo una especie de no cómo decirlo, una hipotensión un poquito asociada a una especie de quizás un problema metabólico, un problema de caquexia o de fragilidad generalizada y a nivel cardíaco no hubo problemas, pero el paciente estuvo un poco hipotenso durante 4 o 5 horas y no entendíamos por qué. Hasta sospechamos si había resangrado o alguna cosa, al final no sangró. Pero la decisión es fácil y juega con un paciente que tiene un riesgo de reinfarto importante, tiene disfunción, y claro, ahora ves el paciente es muy, muy frágil, ¿no?
Sí, bueno, por eso seleccioné este caso, porque es un caso que te plantea muchas dudas de qué tratamiento darle y qué hacer primero, ¿no? Porque también había la opción de operarle de bypass antes de nada, pero ahí nos pesaba el que el sangrado no estaba controlado y que durante la heparinización completa de la cirugía pues podía haber sangrado más, ¿no? Entonces, bueno, era una decisión muy difícil, lo decidimos así y, bueno, de momento hemos completado dos etapas, ahora esperamos a ver si se recupera y también, ahora también, yo creo que también le da mucha tranquilidad al cirujano general de cara a poderlo operar de la amputación de recto con menor riesgo quirúrgico, ¿no? No es lo mismo, es una cirugía muy agresiva también, no es lo mismo operar a este paciente con estas lesiones no revascularizadas que ya revascularizado, ¿no? Por tanto, bueno, no sé, todavía no ha acabado el proceso, pero de momento yo estoy satisfecho con el camino que hemos decidido, ¿no?
Gracias. Hola, excelente presentación, excelente caso, muchas gracias. Tú nos comentabas que no tenías conocimiento previo de los sangrados previos del paciente en los últimos 3 meses y por esa razón el paciente con un síndrome coronario agudo sin elevación del ST recibió antiagregación y anticoagulación plena como corresponde a cualquier otro paciente. ¿Cuál hubiese sido tu estrategia antitrombótica en este caso en particular si hubieses sabido que el paciente había estado sangrando los últimos 3 meses?
Buena pregunta. Mira, yo igual solo le hubiera dado heparina, porque aunque es verdad que clínicamente fue un síndrome coronario agudo sin elevación del ST, porque venía teniendo angina progresiva y el día del ingreso tuvo angina de reposo más prolongada, es verdad que ni hubo cambios en el electro, y la elevación de troponinas que tuvo fue pequeña, sabéis que la troponina ultrasensible se eleva mucho, pero las CKs de este paciente fueron normales, ¿no? Y por tanto, y además tenía una fibrilación auricular rápida que podía contribuir a desencadenar la isquemia, ¿no? Entonces, si yo hubiera sabido que ella venía sangrando, pues igual solo le hubiera anticoagulado con heparina de bajo peso molecular y hubiera esperado a darle ningún antiagregante hasta la coronariografía, ¿no? Y luego, pues la coronariografía afortunadamente en este paciente fue multivaso y fue para cirugía. Hubiéramos tenido un problemón si le hubiéramos hecho la coronariografía, hubiera tenido un solo vaso, le hubiéramos colocado un stent y después en la planta nos enteramos de que sangraba que llevaba 3 meses sangrando y que tenía un cáncer de recto. Ahí sí que hubiéramos tenido un problemón, pero bueno, por suerte no fue así.
Bueno, gracias, Joan.
Vale, gracias.
Felicitaciones. Enhorabuena. Muy buena, gracias, Joan. ¿Cuál? Sí, exacto, la de Renato. Primero Renato, ahora. Cambia un poco el orden, va primero Renato y después Ana.
Muy bien. Nuevamente, gracias, Joan, por una... Ahora vamos a empezar a meternos más un poco en el tema de la hemodinámica, posiblemente con los próximos 3 ponentes. En primer lugar, vamos a cambiar un poquitito el orden que teníamos planteado. Renato nos va a hablar de la terapia antitrombótica percutánea en la sala de hemodinámica. Posiblemente esta va a ser la charla más hemodinámica propiamente dicha o más de hemodinamia que clínica, pero que en el fondo nos va a afectar a los que luego tengamos que seguir a los pacientes y que definir un poquito cuántos van a ser los tiempos y qué antiagregación podamos poner después. Renato, muchas gracias.
Thanks to Joan and Ruben for the kind invitation. It's a very pleasure for me to be here, and it's very pleasure in this place, and it's a very pleasure to meet again Ruben that moved the first steps in the cath lab with my tutorship and with the tutorship of Angela. So I'm very proud to see you again in this contest. So let's move on to my presentation. This is my disclosure, and I underline the disclosure because it's very important also for my presentation. And this has the slide depicts very well the most important steps in the cardiology, interventional cardiology, all the steps, and how during the time we have a decline in deaths in relation to the scientific advances. Thus, so we have all of us know that we have the change in life expectancy. But this change, the huge of this change, is due to the reduction in cardiovascular death. So cardiology has a huge legacy. Oh, we know that we have also different legacies, like the legacy of Nadal. But move on the focus of my presentation. That's my task is to discuss about the management of antithrombotic therapy in the cath lab. After PCI, Angela Migliorini and Marco Valgimigli will discuss very well. And the management in the cath lab involve a different clinical scenario. As acute coronary syndrome, like ST elevation myocardial infarction, non-ST elevation myocardial infarction, chronic coronary disease, and this different clinical scenario involved also the treatment before to achieve the cath lab for the patient. So we have also the important concern about the pretreatment concerning the antithrombotic treatment. And we have depicted also the guideline, the American guidelines, and also the European guideline, and the actor involved in this management. So we talk about ticagrelor, prasugrel, GPI, intravenous antiplatelet therapy with clopidogrel, with cangrelor, and so on. Our guidelines for the oral antiplatelet therapy, which oral antiplatelet therapy? So we have two milestones concerning the trial, the Plato trial and the Triton trial, Plato trial, in which ticagrelor proved to be superior to the standard of care at the time, that was clopidogrel, reducing the composite cardiovascular outcome as a composite of death, MI, or stroke. And so at the same time, in the Triton trial, prasugrel was found to be superior to clopidogrel in patients presented with ACS, reducing the composite of death, MI, and stroke, with just a slight increase in the bleeding. And this trial also, at the current, drive our guideline. We have a lot of trial to compare the most potent oral antiplatelet therapy, prasugrel and ticagrelor. The most important trial is REACT 5 in the setting of ACS, and was found the benefit of prasugrel driven mainly to a strong reduction in the incidence of recurrent myocardial ischemia, mainly in non-ST elevation myocardial infarction. Another trial important in the huge context of our population, the elderly, so in patients with more than 70 years or older, in a setting of non-ST elevation myocardial infarction, we know that a clopidogrel strategy can be not inferior to a strategy with a more potent prasugrel ticagrelor. Although in this trial, most of the patients in the most potent antiplatelet therapy use the ticagrelor. Thus, the trial were involved in the current guideline, and so we have with the indication 2A that prasugrel should be considered in preference to ticagrelor in patients with non-ST elevation myocardial infarction who proceeded to PCI. The other question is when to perform the treatment, the oral treatment. So in this context, we have the ACCOS trial more than years ago by Montalesco, raising the concern of the harm of antiplatelet therapy in the pretreatment setting. So we have only a major incidence of bleeding and no benefit regarding the ischemic events. But I must say that the time of first loading dose and coronary angiography was only of 4 hours, meaning that we have no enough window to gain the advantage in regarding the ischemic events. So we have only the drawback that are the bleeding. In the setting of a primary PCI, the Atlantic trial showed non-clinical benefit in terms of pre-treatment. We are talking about ST elevation mechanical infarction. But that was expected because how have a gain in terms of TMI flow or ST change after the PCI when you use an oral antiplatelet treatment only in the ambulance 1 hour before the PCI. We have not enough time to have a gain in this setting. But anyway, the pre-hospital administration was safe regarding the bleeding. So that was very important from a market point of view. The more recent trial, the Italian trial supported by Italian Society of Interventional Cardiology, was the Dubious, that compared the downstream strategy with the upstream strategy, and showing clearly that there is no a winner strategy. And we have with this trial in the setting of a current situation, because we have more than 90% of radial access, and more of the patient perform the angio within the 24 hours. And the PCI was performed in more than 70% of patients. Surgical revascularization was performed in 60%, and no revascularization was performed in almost 1 for 4 patients. So current guideline, at least in the non-ST elevation mechanical inflaction, we have no recommended pre-treatment routing strategy with P2 Y12 receptor inhibitor in patients in whom the coronary anatomy is not known and early invasive management is planned. From the other side, in patients with non-ST elevation mechanical infarction who cannot undergo an early invasive strategy, pre-treatment with P2 Y12 receptor may be considered depending on bleeding risk. Bleeding risk, we have a lot of data. We know that high bleeding risk, HBR patients, in patients who experience bleeding, we have a strong association with mortality, in terms of mortality, of poor outcome, also in long-term follow-up. So, one of the most important key in the cath lab is the management of the bleeding avoidance strategy during PCI. And the most important strategy we can have is to use a radial access and avoid the routine pre-treatment with antiplatelet therapy. But we have Marco Vagimini here, so we have the MATIX trial published in the Lancet in 2015. That is a milestone of our knowledge. And also the more recent meta-analysis, and we know that a transradial access was associated with the lower mortality, with the lower major bleeding, lower vascular complication compared with transfemoral access. So in our cath lab, we use, all of us use transradial access. Anyway, we have some situations, some circumstances, not only in structural intervention, that we need to use a transfemoral access. And also in our cath lab, you use a transfemoral access, but always guided by ultrasound puncture guided. And so this is an old paper in the 2010 showing anyway that we have a lower complication when we use intravascular ultrasound to guide the puncture. So, why intravenous antithrombotic therapy can be useful in the cath lab? First of all, we have a different clinical situation where an antiplatelet therapy is delayed. I'm thinking about intubated patient vomiting, patient with ST elevation myocardial infarction, with limited pre-hospital care, no pre-treatment in case of elective setting or non-CT elevation myocardial infarction, cardiogenic shock, mechanical ventilation. So we have a lot of clinical situation, a lot of scenarios in which we cannot perform a timely therapy, antiplatelet therapy, or oral antiplatelet therapy. The other concern is the bridging the gap from a pharmacodynamic point of view. We know that at least in the STEMI, in a CT elevation myocardial setting, almost 50% of the patients are in non-responder zone after the loading dose of potent oral P2 Y12 inhibitors. And the other important concern is that the most of ischemic events are clustered in the first hours of after the procedure. In the first 2 hours, we have the most ischemic events. The other important concern is the impact of periprocedural myocardial infarction. So to avoid a periprocedural myocardial infarction is the link with a better outcome. In fact, as clearly shown by this paper, whatever the periprocedural myocardial infarction, syntax definition, fourth definition, we have a link with a poor outcome, also in the long-term outcome, as in 10 years of follow-up. So it's important also to avoid the cath lab a periprocedural myocardial infarction. So what are the drugs, what are the actors in our cath lab? Historically, we have the GPI, currently are mainly considered as a bailout therapy. Why that? Because GPI, yes, is used to achieve a rapid and effective platelet inhibition. However, GPI discontinuation persists, the activity of a GPI persists 4 hours, and sometimes for apixaban persists for days. So we have direct inhibitor of P2 Y12 as Cangolo, that we have a rapid onset, 2 minutes, only 2 minutes to achieve the effect of the drug, and we have a rapid offset with the switch off of the drug. 30 minutes, the drug is off. These are the study or more than 10 years ago that with the comparison of competitor showed the benefit in terms of stent thrombosis, in terms of efficacy, in terms of reduction of composite of the HMI, stent thrombosis, driving the drug that was available, at least in Italy, also in the last 2 years. Cangolo is used also to bridge the therapy in the setting of high-risk patient that must perform surgical surgery and not a major surgery. Is used the discontinuation when we have a high risk. We can use a Cangolo at a low dose called the bridge dose in order to achieve the window before the surgery, and with the switch off of the drug, the patient in 30 minutes can perform a surgery. But the bridging therapy is possible to use the bridge therapy, at least in off-label setting, to modulate, cioè to tailor the dose of Cangolo in order to achieve a different dip of platelet inhibition. We also the aspirin as oral antiplatelet therapy, but we have data in the cath lab use more frequently the flectado del lysine acetylsilate in order to achieve a more efficacy, more fast using instead of oral aspirin. So this is my algorithm in clinical practice in patients with ST elevation myocardial infarction, in patients with shock, in patients with out-hospital cardiac arrest, in patients intubated. So we perform acetyl salicylate intravenous, heparin. So in the cath lab we perform angio, and in case of high ischemic risk we use the standard dose of Cangalor with infusion over 2 hours, plus the crushed ticagrelor, we use the GPI only in bailout setting. But if you have a patient with high bleeding risk, we use the bolus for the procedure, but we can perform a prolonged infusion with a low dose, with a bridge dose, also for the days, with using monitoring test for the platelet reactivity, and we can perform a loading dose of oral antiplatelet therapy only with immunosafe. This is the country trial that in a primary PCI setting, also as demonstrated by Angiolillo in circulation in 2019, that there is no interaction with Cangalor and ticagrelor. Whatever is the time you can administer the ticagrelor. So you can use a ticagrelor before the PCI, before the bolus of Cangalor, during the bolus infusion of Cangalor, or use also after the infusion of Cangalor. And the benefit was more than the standard therapy. We crushed the ticagrelor as used by Dominic Angiolillo. So the rapid onset of Cangalor is very, very, very fast, 2 minutes. So it's not useful to use different administration as using the guide cut during the ST elevation myocardial infarction, as demonstrated our registry in our center. So important, the bridging to the gap is important for the transition strategy to oral P2 Y12 inhibitors. So ticagrelor can be used in every time during the use of Cangalor. Ticagrelor can be used in every phases of infusion or bolus. From the other side, prazoglel must be used at the end of infusion, prazoglel 30 minutes before the end of the infusion, and clopidogrel only after the stop of the infusion. Why that? Because we have different pharmacodynamic reasons. Ticagrelor is in the blood in a huge concentration, is a reversible inhibitor, so attach and they attach in the P2 Y12 receptor, and so Cangalor is on, Cangalor is off, we have ticagrelor in the blood. Differently, prazoglel and clopidogrel have a small bioavailability after liver metabolism, and so when the drug achieve the blood, fast go off, and so if the receptor, the P2 Y12 receptor are occupied, we have no drug after the administration. So this different, the knowledge of this strategy are very, very important to tailor the approach in the management of antithrombotic therapy during these phases. This is the algorithm in my non-ST elevation myocardial infarction. When there is an indication to PCI, so we have, similarly to ST elevation myocardial infarction, concern about ischemic risk, bolus, standard bolus, crash ticagrelor, GPI in bailout setting, and the concern about the bleeding risk, we can use the low dose of bridge with monitoring the test also for the days. We have also the ability of the standard strategy to use only the full loading dose. We crash the oral P2 Y12 inhibitors, whatever that you use. So you can choose the right strategy in different patients to balance the risk of bleeding, to balance the risk of ischemic complication. And also for in patients that are naive, so we have seen the patients that are naive, that we have that have no pre-treatment, but also in patients that have a pre-treatment with prasugrel, with another oral antiplatelet, the use of cannulas could be achieve a more deep inhibition of platelet, as shown by this paper clearly from a pharmacodynamic point of view. So we can see that the inhibition of aggregation after the cannula is very, very low. So, if needed, intravenous platelet therapy by cannula allows a deeper platelet inhibition on top of oral agents. This is an algorithm in my clinical practice for chronic coronary syndrome or elective SANDI. So we have a stage of the PCI. Anyway, in case of ad hoc PCI, you can use a standard strategy as compare in complex or high-risk PCI with the strategy I've just shown in the previous slide. So, important concern is the cost. We can say that, yes, but the cannula is a cost, so you use this strategy. What is the cost? The cost, you can see, is so $700, 800 euros. But anyway, I've shown that also the cost of the other drugs, but most important is the cost of a complication, the cost of myocardial infarction, the cost of bleeding. So you can use also to avoid the strategy, because if you pre-treat the treatment, if the patient needs a surgery, you must wait for 5 or 6 days before the intervention. So the no pre-treatment strategy can lead to a more fast track to perform intervention in the same day or on the day after. So these strategies and this cost regarding the complication are important when you consider cost effective in the use of this strategy or this drug. So the answer also in the cath lab is an individualized medicine, deriving from the best practice, tailored approach, clinical judgment, relevant scientific evidence, patient value and preference. And to conclude, different clinical and procedural scenarios have to be managed in the cath lab. Intravenous antiplatelet agent has to be considered during primary or complex PCI in non-timely pre-treated patient in order to achieve a prompt, effective, and deep platelet inhibition, even as adjunct therapy. The knowledge of pharmacodynamic and pharmacokinetic antithrombotic therapy rationale allows an individualized strategy balancing the expected benefits and harms to decide the right management. We must integrate data from study, trials, guidelines, recommendation, and clinical judgment, making ongoing assessment to navigate the best strategy for each patient. A tailored approach is an individualized medicine area is the key for the management of antithrombotic treatment. Thanks for the attention.
Thank you very much, Renato. Wonderful presentation. I guess following the presentation of Joan with a case with an individualized therapy, this could eventually follow the same sense, because here we are seeing that in one scenario, like for example the SCA syndrome, myocardial infarction, we have maybe some alternatives. There are another alternatives also for patients with a stable situation. That is most important also for the cardiac surgeon. You have demonstrated how we can wait for the pretreatment. We need now to wait for the pretreatment. This is not always the same.
I would like to ask you, after so many years using the double antiplatelet therapy as a pre-treatment in acute non-ST acute coronary syndrome, was it easy to change that treatment in your institution, or are still the doctors at the emergency unit using both antiplatelet agents? Because we've been using aspirin and ticagrelor or clopidogrel for so many years, and I feel like now it's difficult to go back, and in the emergency unit, many physicians are still prescribing the two antiplatelet agents. How was in your institution?
In our institution is the opposite. So no cardiologists prescribe double antiplatelet therapy before the coronary angio. And this practice was changed after the era of Cangelo. So we have evidence of bleeding, the drawback of bleeding with pretreatment. Also consider radial access, so also the facility to avoid the bleeding, the cath lab, avoid bleeding or any vascular complication. But when we have the availability of cannula, there is no pretreatment before coronary angio. And sometimes, if you consider, you must perform an indication before angio by interventional cardiology. Otherwise, there is no pretreatment until the angio is performed.
And another
so
question.
We have a huge use of cannula strategy in different settings.
And another question I would like to make you is about the femoral approach guided by ultrasound.
Yeah.
Is there the rate of vascular complications is the same if you do femoral approach with ultrasound, guided by ultrasound, than the radial approach, or is it still higher than the radial approach? I mean, and if it's the same, what do you prefer? Do you prefer the femoral approach with the guidance of the ultrasound, or do you still prefer the radial approach to minimize the risk of vascular complications?
Right question. Yeah. I have, when I was born as an interventional cardiology, there was only transfemoral access. So the transition to transradial access with a lot of evidence, the milestone of the paper of Valgimigli is one of the milestone. So also in our cath lab, we have performed the transition to transradial. Anyway, it's not so important for me or for Angela Migliorini that we have performed more than 50,000 angio, transfemoral angio. But it's now for young people, so they use transradial access. So femoral access is quite, it's rare. Also, if you perform structural intervention, because you perform 1,000 procedures, 900 are for transradial. So it's mandatory. So in the cath lab, the young people who's my young colleague is mandatory by me to use intravascular ultrasound. And the rate of vascular complication and bleeding is the same that transradial access now. Yes. Also we have a important change also in the structural intervention. Using the intravascular guided puncture in the TAVI setting or mitral clip, whatever you want, venous or arterial access, we have a low rate of vascular complication and bleeding because they're really very safe. Yeah, also, if you have available the angio CT scan, because you choose the roof where to puncture, the quality of the vessel, and you during the use of the ultrasound guided, you can perform a lot of the confidence, the hand, the sound, the guide, the puncture. So the complication rate in terms of bleeding and vascular are very, very, very low. I cannot say low, oh, it's impossible, but very, very, very low.
Maybe, but we don't. Although with these tools they reduce a lot the risk of vascular complications, we have to keep in mind that probably the patient prefers the radial approach because he's more comfortable after the procedure. No?
Of course, yes.
So,
of course.
So if the rate of complications is the same, probably to improve the patient's confidence, it is better to continue with the radial approach.
Yes. Anyway, also in the coronary set, it's impossible to have also only transradial as at least if you perform a very, very high complex PCI. With you must use a rotablator with a large bore. If you use a shockwave, you must use so much. Okay, it's impossible to use only transradial access. But anyway, for this reason, if you also in coronary setting, the rate of use of transfemoral access is only 5%, so it's dangerous. So to maintain the skill, the ability to perform a right puncture is important. So in our team, I use also for the angio, not for PCI, but to achieve a confidence with ultrasound guided puncture, to achieve the confidence. So now it's always.
Dr. Merino.
Thanks. Oh, thank you for your review. Very thorough and no leaks left. Thank you. Especially if your experience with Kangaroo was very useful, at least for me. Then, but you talk about antiplatelet agents. How do you manage with heparin in high-risk bleeding patients? Which doses, which heparin you use? There's some tricks you can give us?
Yeah, so right question. I use heparin to achieve an AC time 250. Always. Also in high-risk bleeding, because I perform the procedure with heparin on board plus cangulos.
No reduction in ACT with Cangalor or...
No. Cangulos, the dose is 4 kilogram and time, so we don't need to... We can use a different dose for different clinical scenario. It's an off-label indication, as I've just said in my presentation. Anyway, if I have a very, very high-risk patient for bleeding, so I don't use oral antiplatelet agents. The use of a low dose, the bridge dose of Cangro is more safe. Mm-hmm. And you can perform a monitoring of this by using daily PRU, by using a platelet activity test, in order to know where we are in the responder or high responder zone, and so to tailor the dose in relation of reactivity test. Mm-hmm. If you are too low the dose of Cangalor. If you are too high dose of Cangalor. This individualized management is the key to reduce ischemic and bleeding complication for the patient.
Totally agree. We also tailored with
the tailored approach.
You use Verify now, right? You use the Verify now.
Yeah, but it's not so important. Whatever is the bedside approach for also other platelet tests, it's not important. The important is to use and to have the confidence to use the answer of the test with your therapy. So we must to achieve a confidence in the use. Before of verify now, we used the light transmittance aggregometry, but it was not a bedside, but in the laboratory. Anyway, in this case, we had different platelet inhibition. We can modulate also the oral antiplatelet therapy with the platelet inhibition. Anyway, whatever the test use, it's important to achieve the confidence with the test, and you believe it. You must believe it.
No, we use it and totally agree. Thank you.
So I think that Angela showed clearly other clinical scenario in which platelet activity test is useful for the individual management on antithrombotic therapy. Se vi rispondo in italiano faccio anche meglio.
Yes, from the clinical point of view, because I have seen on your outcomes, you didn't. There is no loading dose of agents, so and there was no evidence of using loading dose of prasugrel in the pre-treatment rather than exceeding of the bleeding risk. How do you do with the? Do you have a fast track of protocol with organization of the pre-treatment hospital for not using this dose of overload once the patient has reaching the PCI lab? I mean, those patients doesn't receive those loading dose rather than in a fast track for your medical practice or your protocol treatment. What does an emergency doctor can do if already a giving of loading dose have been done?
In our territory, there is a network, but nobody uses a pre-treatment.
Okay.
So most of patient arrives in the cath lab in the emergency or urgent setting without pre-treatment.
So there is well organized. They know what to do.
Yes, but probably, see, but the reason is not what I've showed. The reason is a market a cost. Is the cost in the network, ambulance, so there is no oral antiplatelet therapy before to achieve a cath lab.
How do those emergency doctor knows if the patient is going to go to a cath lab for those practice rather than normal strategy, which is from the emergency doctor or ambulance doctor, when usually I am an internal medicine doctor and I have been working in emergency departments. And normally we know time is muscle, or muscle is time, that we have to gain time as soon as possible. How do they know not to?
I don't think that is an issue, because in ST elevation myocardial infarction, also if you perform an oral antiplatelet loading dose 1 hour, you have a protection in the primary PCI.
Okay.
There is no protection. We have shown this concern 10 years ago with a rapid trial, showing that, as I have showed, most of patients after 2 hours of loading dose are in non-responder zone. So it's important for the therapy, not for the PCI therapy. This is very important. So in the cath lab, you perform a PCI without a protection, only with oral antiplatelet agents. So if you look at the history, so the American style used for the primary PCI bivalirudin. Where is bivalirudin? Where is? Nobody uses bivalirudin. Why that? Because it's not different from heparin, first of all. And there was the problem of bridging the gap in which most clinical events, most ischemic events occur in the first 2-3 hours after PCI, after primary PCI in these cases. If I remember right, also the milestone of MATIC trial by Marco Valgimilli, there was a double randomization with transradial access and bivalirudin with heparin, right, Marco? Right. Anyway, so if you perform a primary PCI, whatever the loading dose, at least 6 hours, okay, fine. Best loading dose before, yes. But anyway, there is no benefit, no clinical benefit. So if the time from pre-treatment and the angio is very short, we have no advantage in terms of clinical ischemic events. And the other side, we have an increase of bleeding risk.
Which is the benefit is the access to a PCI lab.
Yes, the benefit should be probably if we have more than 1 day without angio, because it's a therapy. It's not related with PCI. It's related with the patient. So this is my opinion, at least.
Molto bene. Thank you so much. Thank you so much. Nice presentation. So, Andrés.
Gracias. Gracias, Rubén. Muchas gracias, Renato. Un placer la presentación. Ahora, por suerte, nos podemos quitar el traje plomado y salir de la sala de hemodinámica, para los que somos cardiólogos clínicos. Va a ser un placer introducir a Ángela, que también viene de una de las ciudades más lindas del mundo a otra de las más lindas del mundo. Viene de Florencia también, para que nos enseñe la parte que más nos interesa posiblemente a los clínicos, que es lo que vamos a hacer después de que ya los fontaneros nos han destapado los caños, ¿no? Un placer. Adelante, Ángela.
Okay. First of all, I would like to thank Rubén Vergara for this kind invitation, and it's a pleasure for me to meet him again. He's a very close friend, and I haven't seen him for such a long time, so it's a pleasure to be here to meet him again. My presentation will be about antithrombotic therapy after PCI, so from evidence to an individualized management. Okay, this first slide shows the physiopathological process that lead to atherosclerosis. We know that in acute coronary setting, when plaque rupture or erosion occurs, the activation of a coagulation cascade and platelet activation can lead to either subocclusive or occlusive thrombosis, and then this causes an acute symptomatic event. In patients with chronic coronary syndrome, plaque progression and healing phenomenon occurs while formation is very contained. A repeated cycle of this process promotes disease progression. These are current recommendations on the use of dual antiplatelet therapy after PCI. The dual antiplatelet therapy after PCI is mainly necessary due to the reduction of periprocedural complications like vessel occlusion, vessel dissection, macro embolization, and acute and subacute stent thrombosis. On the other hand, however, dual antiplatelet therapy may also prevent long-term ischemic events and also the atherosclerotic plaque progression and destabilization in both coronary and extracoronary vascular. This is a slide that summarizes the limitation and the benefit and limitation of a clopidogrel drug. This is the most widely used P212 inhibitor, and despite its benefit, clopidogrel has also some limitation, most of all the wide variability in drug response. In fact, patients treated with clopidogrel may have a high residual platelet reactivity during on-track treatment, patient. And this variability depends on genetic polymorphism due to the reduced conversion of a prodrug to the active drug by hepatic enzyme, and also by clinical variables like older age, chronic renal insufficiency, and diabetes mellitus. So the prevalence of an inadequate response to clopidogrel loading ranges from 4 to 54% in the general population. Due to this pharmacological limitation associated with clopidogrel, patients were exposed to an increased risk of adverse clinical events like myocardial infarction, stent thrombosis. This has led to the development of newer antiplatelet agents with more favorable pharmacological properties. This is an historical work of our group, and that shows that high residual platelet reactivity after clopidogrel loading has a strong impact in terms of long-term cardiovascular events. You can see that high residual platelet reactivity after clopidogrel in patients with acute coronary syndrome undergoing PCI is associated with an increased risk of cardiac mortality and MACE. This slide summarizes the characteristic of different P2 wild 12 inhibitors, and the newer agent prasugrel and ticagrelor compared to clopidogrel have a more potent, more predictable, and more rapid effect. That's why the use is mandatory in acute coronary syndrome, and especially in ST elevation myocardial infarction. This slide summarizes the time course of benefit and risk of DAPT after PCI. DAPT after PCI may reduce the incidence of stent-related ischemic events, such as stent thrombosis or target vessel revascularization, reduce the incidence of cardiovascular ischemic recurrence and their consequences, such as myocardial infarction and cardiovascular death, and prevent cerebrovascular events in other areas affected by atherosclerotic disease, such as peripheral and carotid arteries, but is inevitably associated with an increased risk of bleeding. So the potential benefit of antiplatelet agents varies over time, with the greatest benefit in terms of less ischemic event, which is maximized during the first month after PCI, and decreasing over time, while bleeding event remains stable in time. So bleeding is the main drawback of antithrombotic therapies, and given its association with adverse prognosis. This is a slide that shows the comparative of efficacy and safety of a newer antiplatelet agent when compared to all the old clopidogrel. Ticagrelor therapy compared to clopidogrel is associated with the reduction in cardiac mortality, and prasugrel compared to clopidogrel is associated with the reduction in myocardial infarction. Both therapy, prasugrel and ticagrelor, anyway, are associated with an increased risk of bleeding events. So, when we consider how to approach and how to individualize a dual antiplatelet therapy in any single patient, we have to consider three key factors, three fundamental factors. First, the bleeding risk, as was said before in the first presentation. Second, the ischemic risk of a patient. And third, the responsiveness to dual antiplatelet therapy. Bleeding risk and ischemic risk include both not only clinical variables, but also procedural variables that may affect in itself the ischemic and bleeding risk of the patient. This is a slide that has already been shown by Renato, and this is validation of academic research consortium high bleeding risk. And these slides show that in patients with PCI, but who are considered at high bleeding risk, they experience more bleeding events during long-term follow-up, but they also experience more ischemic events during long-term follow-up, like cardiac mortality and myocardial infarction. There are many mechanisms that explain the link between bleeding and ischemic complication. These mechanisms include the interruption, for example, of dual antiplatelet treatment, the activation of coagulation and inflammation after bleeding, the need for blood transfusion, which modulates oxygen exchange at the tissue level, and favors vasoconstriction and platelet aggregation. So these considerations have stimulated interest for tailoring dual antiplatelet therapy according to the ischemic and bleeding risk of the individual patients. So what we have to consider when administering a dual antiplatelet therapy after PCI, there are many considerations to do. Advances in antithrombotic and antiplatelet therapy with newer antiplatelet agents have improved outcome following PCI through the reduction of ischemic events. At the same time, the newer stent technology and the better stent implantation technique with the use of intravascular imaging have improved the short and long-term procedural outcome of PCI. So the meticulous procedural strategy guided stent implantation can reduce the need for longer DAPT. On the other side, patients who receive multiple stents, longer stent implantation with diffuse disease may benefit from a prolonged DAPT. So a patient's ischemic risk profile depends on multiple factors. We also have to consider that the prognostic impact of the neoatherosclerosis or of the progression of atherosclerotic non-culprit lesion plays a fundamental role in determining future cardiovascular events. So patients with a high atherosclerotic burden may derive greater benefit from a prolonged DAPT duration. However, patient bleeding risk profile and bleeding complication remain a significant and harmful consequence of utilizing DAPT. Through the year, hemorrhagic complications remain significant and are now considered to play a central role, a key role in the choice of DAPT and duration of DAPT. For all these reasons, the optimal duration of DAPT is still a matter of debate and influenced by multiple factors. This strategy summarizes the different strategies that has been studied, and they are focused on balancing the bleeding risk and the ischemic risk after PCI. First of all, the shortening of DAPT duration, so shortening of DAPT not till 12 months after PCI. And the use of, after a brief period of short DAPT, the use of P2 wild-12 inhibitor as monotherapy in selected patients. Again, there is a possibility to perform a de-escalation or an escalation approach to select the best P2 wild-12 inhibitors for the single patient. This de-escalation or escalation may be performed also by guided platelet functional test or genetic test. Again, there is a possibility to extend long-term DAPT duration in very selected patients and to use a vascular dose or anticoagulation. Finally, how to use DAPT in patients who need also oral anticoagulation because affected by atrial fibrillation. This slide summarizes the randomized controlled trial that compared the shortening of DAPT with standard DAPT or extended DAPT duration. And most of this trial that in which a short DAPT was 3 or 6 months, showed that short DAPT has a comparable result with the standard DAPT duration in terms of MACE, but in most of trials, shortening of DAPT was associated with a reduction in bleeding events. This is data from the Twilight trial, and in this trial, a patient with one clinical or angiographic feature associated with high risk of ischemic bleeding events were randomized after 3 months of DAPT to ticagrelor plus aspirin or ticagrelor alone. In this trial, ticagrelor alone was associated with a reduction in bleeding event without no difference in terms of MACE rate. This is a subset analysis of the Twilight trial that included only patients who were treated with complex PCI, and in this subset analysis, patients undergoing complex PCI had similar result as the total cohort of patients. In fact, after 3 months of ticagrelor plus aspirin, continuation of ticagrelor monotherapy was associated with lower incidence of bleeding without increasing the risk of ischemic event compared to ticagrelor plus aspirin. This is a recent meta-analysis that compares short DAPT duration followed by P2 wild-12 inhibitor monotherapy versus prolonged DAPT duration after second-generation drug-eluting stent. And this meta-analysis shows that 1 to 3 months of DAPT followed by P2 wild-12 inhibitors reduces minor bleeding compared with prolonged DAPT. So this advantage does not occur at the cost of an increase in stent thrombosis and major cardiovascular endpoint like all cases of death, myocardial infarction, and stroke. So single antiplatelet therapy with P212 inhibitor is an appealing strategy and may limit the need for DAPT after disimplantation. This is a master TAP trial. I know Marco will discuss about that with more knowledge and competence than I can do, but this is a very important trial, so I cannot mention it. This is a trial included patient at high risk of bleeding, and after 1 month of DAPT, after last generation drug-eluting stent, patients were randomly assigned to discontinue DAPT, abbreviated therapy, or to continue it for at least 2 additional months. 1 month of DAPT was not inferior to the continuation of DAPT for at least 2 additional months with regard to the occurrence of net adverse clinical events and to the occurrence of minor adverse cardiac or cerebrovascular events. Abbreviated therapy resulted in a lower incidence of minor or clinically relevant non-minor bleeding. So now we have seen that short DAP is safe and may be efficacy. So it's safe in terms of MACEs and may be efficacy in terms of reducing bleeding event. But however, in our clinical practice, we often find patients who are both at increased risk of ischemic event and increased risk of bleeding. And this risk may vary over time. However, moreover, we have also patients who may have bleeding risk or ischemic risk that are not contemplated in randomized trial, like friability or very older patient. So an approach with a de-escalation or an escalation of P212 inhibitors may be considered. In fact, we have said that clopidogrel is frequently associated with residual high platelet reactivity, and this is the link for a higher risk of thrombotic event. On the other hand, the newer antiplatelet agents cause a low platelet reactivity and may be associated with an increased risk of bleeding. So clinicians, keeping in mind all what we have said, considering all the risk of the patient, can escalate a switch from a less potent agent, clopidogrel, to a more potent agent, ticagrelor or prasugrel, or can de-escalate in the treatment, switching for a more potent agent, prasugrel or ticagrelor, to a less potent agent, clopidogrel. For example, in acute coronary syndrome, the objective of a de-escalation approach is to reduce bleeding risk of the patient without compromising efficacy, whereas in chronic coronary syndrome, the objective of a de-escalation approach is to reduce thrombotic complication without compromising efficacy, safety. Thus, in this context, platelet functional tests or genotypic testing might be of utility in ischemic and hemorrhagic risk stratification and in tailoring P212 inhibitor therapy. In recent years, multiple rapid bedside assays have been available, enabling easy implementation in routine practice. However, evidence from randomized and observational studies of platelet functional tests or genetic tests have not given a positive result. So these studies do not support the routine use of these tests to guide the selection of antiplatelet therapy in all patients undergoing PCI. But this tool may be of useful in very selected scenarios. This is a meta-analysis recently published on Lancet, and this meta-analysis compare guided versus standard antiplatelet therapy in patients undergoing PCI. This meta-analysis included more than 2,000 patients, showed that the strategy of a guided selection of antiplatelet therapy reduced the risk of minor adverse cardiovascular events. Outcome vary according to the strategy that is used for guided therapy, escalation or de-escalation. So an escalation approach is associated with a reduction in ischemic events without an increase in bleeding, and a de-escalation approach was associated with a reduction in bleeding without an increase in ischemic events. This is a consensus document that was performed by key leaders and with great expertise on platelet function and antiplatelet therapy. And you can see that even if in most of cases of patients treated with PCI, general recommendation of the guideline can be followed considering the type of DAPT and the duration of DAPT. In very selected cases, considering also the clinical and procedural characteristic, the use of platelet functional test or genetic test may help to stratify the risk of the patient. In fact, after this test, after performing the platelet functional test, patient may be shared in patient with low platelet reactivity or high platelet reactivity. Patients with low platelet reactivity have a high risk of bleeding and may try benefit from a de-escalation of the therapy. On the contrary, patients with a high platelet reactivity after the test may have an increased ischemic risk and may find benefit from an escalation approach of a dual antiplatelet therapy. So we have seen that short DAPT is safe and this efficacy. We have seen that we can escalate or de-escalate on DAPT, considering the risk of the patient, bleeding and ischemic risk. The question now is when it's necessary to extend long-term duration of dual antiplatelet therapy. So the observation of patient with diffuse disease, with diffuse coronary artery disease, patient with previous myocardial infarction, patient with diffuse atherosclerotic disease other than coronary disease remain at high risk for ischemic events, has led investigators to assess the safety and efficacy of prolonged DAPT in this setting of patient. So the study has been focused not only in stent outcome, but in patient outcome. This is a Pegasus trial. This trial randomized patients with prior myocardial infarction who had at one of the following additional high-risk factor, and the patients were randomized to low dose of ticagrelor, standard dose of ticagrelor, or aspirin. This trial shows that both doses regimens of ticagrelor were associated with a reduction in mesis rate at long-term follow-up. There was an increased risk of bleeding event, of course, but the net clinical benefit in terms of bleeding and non-bleeding side effect was more favorable for the low dose of ticagrelor, and this is the reason why this dosing regimen may be considered in secondary prevention in patients with previous myocardial infarction. This is a subset analysis of the Pegasus trial, show the same benefit effect of ticagrelor in patients who were treated with pre-PCI and patients who were treated without, who had not a history of pre-PCI. This is another meta-analysis that compare all strategies that we have talked about. Short DAPT followed by P2Y12 inhibitor as monotherapy, a short DAPT duration followed by aspirin, a mid-term duration of DAP, and extended term duration of DAP, who were compared with the standard duration of DAP of 12 months. And extended term DAPT was associated in the total cohort of a patient with a higher risk, with a lower risk of myocardial infarction, but it was also associated with a higher risk of bleeding. In the acute coronary syndrome subset analysis, extended term DAPT was also associated with a reduction in myocardial infarction, but there was significant increase in the bleeding events. Here a slide just to show the COMPASS trial that introduced the concept of the vascular dose of rivaroxaban in patients with diffuse atherosclerotic disease. Patients who have diffuse atherosclerotic disease other than coronary were randomized to low dose of rivaroxaban plus aspirin, rivaroxaban standard dose alone, or aspirin alone. At long-term follow-up, a patient randomized to rivaroxaban low dose plus aspirin had a reduction in terms of mesis rate, and there was a net clinical benefit outcome in the patient treated with rivaroxaban low dose plus aspirin compared to aspirin alone. So the result of this trial support long-term intensified antithrombotic regimens by means of dual pathway inhibition in patients with diffuse vascular disease. Last slide, just to show how to manage a dual antiplatelet therapy in patients who need oral anticoagulation because affected by atrial fibrillation. This meta-analysis compare all the possible association of oral anticoagulation with antiplatelet therapy, and we can see that compared with vitamin K antagonist plus dual antiplatelet therapy, the novel oral anticoagulation plus monotherapy with P2 while 12 inhibitor is the best strategy to reduce in terms of safe, including intracranial hemorrhage. But there were no difference among the different regimens in terms of MACEs. An antithrombotic regimen in which aspirin is discontinued few days after PCI appeared to be associated with fewer bleeding events, with preserving antithrombotic efficacy. So the finding of the meta-analysis support the use of NOAC plus P2 while 12 inhibitor as monotherapy without aspirin, while the lowest rate of bleeding is, with the lowest rate of bleeding and similar rate of ischemic event. These are American perspective and a European perspective showing the same message. In patients who need oral anticoagulation and who need DAPT after PCI, aspirin discontinuation may be done very early, even after 1 week up to 1 month. So in conclusion, antiplatelet therapy represents the cornerstone of treatment for prevention of local and systemic ischemic complications in patients with coronary artery disease undergoing PCI. Over the past decades, different antiplatelet regimens using aspirin and PT while 12 inhibitors have been developed and implemented in clinical practice. A better understanding of the ischemic risk profile and bleeding risk profile of the patient has been instrumental in defining the optimal regimen for the individual patient. Strategies developed to mitigate the risk of bleeding include shortening of DAPT duration and P2 while 12 inhibitor as monotherapy. The use of platelet functional test, genetic testing, can be of aid in selection P2 while 12 inhibitor for a tailored approach of the patient, reducing the risk of bleeding and reducing the risk of ischemic event. Patients at increased ischemic risk may be considered for prolonged and intensified antithrombotic therapy, either by means of a prolonged DAPT or dual pathway inhibition, low dose of rivaroxaban. In patients with atrial fibrillation treated with PCI, novel oral anticoagulation should be preferred to vitamin K antagonists due to the lower risk of bleeding. Triple antithrombotic therapy, the association of NOAC with DAP, should be as short as possible, 1 week up to 1 month, based on the individual's ischemic and bleeding risk profile. So an integrated approach, including scores, definitions to define ischemic and bleeding risk, procedural characteristics, and tools to assess drug response, represent the most promising approach for a personalized selection of the antiplatelet therapy among patients undergoing PCI. Thank you for your attention.
Beautiful presentation, Angela. Thank you so much.
Hello. Just one little question, just also from the clinical side. Yeah, in the last years there's been a discussion, and all the studies show that maybe one is better than the other. It's not very clear which one between ticagrelor and prasugrel. Both are medications, and they have thrombosis. One of them, with no doubt. In your experience, which one is the one that you would choose normally, or is there a specific patient that you would choose one or the other?
Of course, prasugrel has contraindication, for example, in some patients, so we can use in patients with had a previous transit or cerebral attack. In our clinical practice, up to date, is because we use a lot of cangrelor, we use very often ticagrelor for a patient in urgent PCI. In some selected cases, especially young people with very diffuse thrombosis and very diffuse coronary artery disease and who are at very low risk of bleeding, we use prasugrel, but it's only an individual choice. We don't have a protocol for that.
excellent presentation. What are your thoughts about eliminating for good aspirin loading dose from the moment of the PCI in acute coronary syndromes and just started with NOAC and P2Y12 inhibitors?
What we usually do in patients who are treated with NOAC, who have been treated with a stent, we use a triple antithrombotic therapy just for the hospital stay. At a hospital discharge, we perform a platelet functional test, especially in patients who are under clopidogrel, just to test the responsiveness to clopidogrel of a patient, because in this very early phase, the patient can be, after stent implantation, can also be considered at high increased thrombotic event. So we perform tests routinely in these cases.
It is an important concept that you can stop the double antiplatelet therapy in a patient with new anticoagulant therapy also as soon as, for example, 1 week. This is a more useful. It's a useful tool for the clinician, for example. It's a new approach to the patient treated with the stents.
Yeah, the concept of a test is very particular, because we don't use general. It cannot be generalized, but there are some very selected scenarios where it may be very useful. For example, patients who have a stent thrombosis, patients who have to undergo to a cardiac or non-cardiac surgery, so we monitoring, we are doing every day platelet functional tests to monitor platelet function and to decide which is the best moment to send the patient to the surgery. Or, for example, patients who are under dual antiplatelet therapy and experience a bleeding event. So we test the dual platelet function to realize if patient has a high responsivity to P2Y12 inhibitor and may need a de-escalation approach. So there are very selected cases where we do perform platelet functional test or genetic testing.
Okay, thank you so much, Angela. Nice presentation, and thank you again.
Thank you.
My friend.
Muy bien. Vamos a continuar un poquitito con la misma línea y volver un poquitito al principio de la línea, ¿no? Al paciente de alto riesgo. Posiblemente esta charla nos orienta más para ese lado. O sea, para estos pacientes ya no es el paciente fácil, el simple que le vamos a dejar la terapia de rutina. Tenemos que pensar en si realmente le podemos reducir los tiempos. El doctor, que viene específicamente de haber hecho una presentación, un ensayo sobre este tema, nos va a tratar de ver cuánto es ese menos es más, como pone en su charla, o sea, realmente hasta cuánto podemos realmente reducir este tiempo de doble antiagregación. Gracias.
Thank you. Thank you very much for the introduction and for the invite and for the possibility to be here, especially Ruben and Joan, for this very kind invitation to be in this wonderful island. Well, in fact, the title speaks about the APT duration. I will try to have a slightly more helicopter view and try to discuss with a broader concept what do we know with respect to HBR patient, which I think is a good thing to do, because in fact we opened the session today speaking about HBR, how they are, how do we define them, and how should we treat them. So historically, HBR patients have been completely neglected by studies for two reasons. Sometimes they were simply not included, or sometimes they were included, but we didn't know they were HBR because an HBR definition was completely missing. Now we do have an HBR definition, and we heard some hints how an HBR patient can be identified. That gave us, in the last 10 to 20 years, a little bit more emphasis in investigating specifically HBR patient. And in the last 5 to 10 years, we have seen two groups of studies actually addressing HBR. One group is summarized on your left-hand side, which is trying to have a fixed the APT duration and change the device that the patient has received for coronary revascularization, so meaning the stent type. Then there is a second group of studies, which is summarized here on your right-hand side, which basically has done a complementary job. Stent has been fixed, and then the APT has been changed. These completely different group of studies are giving us two complementary answers. But we need to understand which study is giving out which question. The first one is addressing basically the starting point of a clinician who says, I think this patient, because of the HBR status per se, will never be able to afford anything longer than 30 days of DAPT. Which stent should interventional cardiology be implanting if a PCI is needed in that individual patient? That is the question which is addressed by the first group of studies. And basically the answer we have today has provided a sort of a paradigm shift. We believed, or many cardiologists actually were completely convinced that bare metal stent per se were safer than the drug-eluting stent. Drug-eluting stent were more effective but less safe. These studies have changed the paradigm completely because these three studies, ZEUS, HBR, Leaders Free, and Senior, have done an exercise which was, let's give 30 days of DPT to my patients and let's see what is the effectiveness of DES versus bare metal stent. And here you have the answer. In all three studies, the MACE rate, the rate of major adverse cardiovascular events, was lower in patients receiving whatever type of drug-eluting stent. In these two studies, the benefit was not only driven by reduction in target vessel revascularization, which was a little bit of a given, but also the risk of MI was lower. So these two studies showed once forever that irrespective of the APT duration, a bare metal stent is an inferior technology. If you ask a more complicated question for which today we do not have an answer yet, meaning now we know that we need to use drug-eluting stent, do we have a favorable drug-eluting stent to be used in HBR patient? The answer is we do not know today. The only head-to-head study between two drug-eluting stent is the Onyx one, which was published in the New England Journal of Medicine a few years ago, which compared biofreedom drug-coated stent, so a DES without a polymer, with the DES with a durable polymer. The study was supposed to test the non-inferiority of Onyx versus the Leaders Free stent, if you will, and you see the event rate at 1 year was basically identical, 17.3% in the two stents. And if anything, if you dig into the data, the stent with a durable polymer may even seem slightly safer than the one without the polymer. Not if you look at the overall MI, because you have a sort of whatever reason that I cannot explain, slightly higher event rate in patient receiving no polymer stent. But here you see something different. If you look at spontaneous MI, so basically not the MI related to the PCI, but the one that occurred thereafter, spontaneously, there is a trend disfavoring the thicker stent, which is the one without the polymer. And a sort of also disfavoring trend for the rate of stent thrombosis, which is perhaps more telling us the story that stent safety comes more from the thickness of the stent than the fact that the stent has or does not have the polymer. And now we will be not now, but in few months, we will be presenting for the first time the result of the BioFlow DAPT, which is very interesting study because it's comparing actually again the so-called winner of the prior study, Resolute Onyx, with a much thinner stent, which is Orsiro. This DES is very thin, only 60 micron. And so we will have a chance to see whether this paradigm that telling us that the thickness of the stent is probably more important than the presence or absence of the polymer is going to be true. Now, walking very quickly through the second group of studies, the one that compare different DAPT duration, this is the first one we have had in the HBR space. Angela has shown us a huge amount of studies on DAPT duration, but those were in unselected patients. Those only done in HBR patients are the one I'm gonna showing you right now. The first one is the Volve Shore DAPT. Unfortunately, this is not a randomized control study. This is a single arm registry, which was daring to treat with 3 months DPT only patient with HBR, without MI, without complex PCI, compared with an historical group, which was the DAPT study. Now, this registry, because that's what it is not a randomized control study, showing that the event rate seems to be very comparable. In this study, the non-inferiority was met, and also the rate of stent thrombosis, despite 3 months of DPT, was very low. Along the same line, the science short DAPT program is much larger than the Evolve DAPT. I had the privilege to co-chair this program with Roxana Mera from United States. This is a much larger program, which is giving us for the first time also data on 1 month DAPT and also 3 months of DAPT. But the caveat here that unfortunately this is again not a randomized control study, and also in this program patients were highly selected. STEMI patients were not included, patients who underwent complex PCI were not included. With this caveat, the primary endpoint, which was the composite of death or MI, was pretty much similar in patients treated with 3 months DPT versus 1 year DPT, and this met the non-inferiority. And the same was true for 1 month DPT versus 6 months of DPT, which also met non-inferiority. So basically what I'm telling you there, these registry data are suggesting that shortening DPT more and more is perhaps not that bad as we thought some years ago. With the caveat that these are registries, not randomized data, and the caveat that patients have been selected. So these were not all-comer PCI patients. The only study which today has done the exercise of including all patients as long as they are HBR, irrespective of clinical presentation and PCI complexity, is the Master DPT study, which we presented last year. We selected only HBR patients, only patients who received this specific stent, which is the Ultimaster stent. We let the patient be on DAPT for 30 days, and as long as they were free from recurrent complications, they were randomized to immediately stop the APT, and then continue with a single antiplatelet therapy for 11 months or 5 months if there was a concomitant indication to oral anticoagulation, meaning patients who were on OAC were left on OAC monotherapy from 6 months onwards after PCI, versus what probably still today is seen as a standard of care, which is at least 2 or 5 months of DPT in patient with or without indication to oral anticoagulation. Then, when according to the clinician DPT had to be stopped, the patient had to stay on single antiplatelet therapy. Now, you randomize the patient, so you want to see if the patient did what they were supposed to, and the answer is yes. That's the adherence to the protocol mandated regimen was very high in the 2 study groups, which is basically telling you that the patient in the short DPT group did stop DPT at 1 month, and the others did not stop at DPT at 1 month. The average treatment was 34 days in the short DPT arm and 6 months, with a very broad interquartile range, which goes from 2 months up to 1 year of DPT duration, which does reflect the uncertainty that we have in practice. It's very difficult to decide which DPT duration. If you ask that question 10 different people, you will get 10 different answers. And that's what you get here. If you leave the door open to let the clinician decide, the clinician will decide whatever. An important information is, however, here. When DPT was ceased, the study allowed clinicians to choose the antiplatelet therapy they wanted. And the clinician gave a very interesting answer. Aspirin was chosen in only 29%. The winner was in fact the P2Y12 inhibitor monotherapy, and among them the winner in this HBR population was clopidogrel. Then we have a reasonable representation of ticagrelor, 14%. Prasugrel is hardly visible, there is no prasugrel. And that's interesting because that comes from the clinicians. Now, against this background, we designed the study to show the non-inferiority on NACE, which was met. The event rate were slightly in favor of abbreviated DPT, that met the non-inferiority. Then if NACE non-inferiority was met, we were allowed to test the non-inferiority for MACE, so only ischemic events, and that was also very similar, 6.1, 5.9, non-inferiority was met. And finally, since we had no signal of higher ischemic risk, we, of course, were interested to the potential benefit, and the benefit is a massive difference in bleeding, which is, of course, highly statistically superior, but most importantly, the magic number is this one, the number needed to treat for benefit. The p-value does not tell you anything. This number is very informative for clinicians. That means for every 35 patients you treat with 1 month DPT instead of prolonging that regimen, you would actually avoid 1 bleeding, which is quite an impressive result. Now, when we presented the study, then, of course, clinicians, also interventional cardiologists, remained very surprised. Yes, perhaps because you have a mixed bag of MI patients and stable patients. Then we did the analysis MI versus CCS. That has not been published yet, but has been presented last year by Peter Smits at TCT, and we showed that MI or not MI, that did not play any role. The results remain identical. 1 month ago, we presented a new analysis and published in the European Heart Journal, which is the complex PCI. We looked into those patients who underwent complex PCI versus patients who did not undergo complex PCI. And this is the definition of complex PCI. Basically, if at least one of these 6 criteria is met, the patient was labeled as a complex PCI. We ran sensitivity analysis because many would perceive that left main stenting is also belonging to the complex PCI. Many would say even graft stenting is a complex PCI. So we also added these 2 criteria. We added the additional complex PCI or complex patient definition, which was let's look into patients who either underwent complex PCI and or had an MI at presentation, or let's look into complex PCI and MI at presentation. At the end of the day, whatever we did, we obtained the same results, which is shown here. There is no difference with respect to NACE in patients receiving one or prolonged DPT, irrespective of whether they were complex or non-complex PCI, nor difference with respect to MACE, and there was a clear benefit with respect to bleeding. And in fact, if you look carefully into the line, if you look at the absolute risk differences, there were even greater in complex PCI patients. So basically, the study does not show in any way that HBR patients should be receiving anything that 1 month DAPT followed by single antiplatelet therapy. So in conclusion, to summarize where we stand for this specific segment of HBR patient, bare metal stent have today no place, even in HBR patient, because not only they are associated with greater risk of target vessel revascularization, but more importantly, they are less safe than BMS, also higher risk of MI. And for the clinician, that's very informative, because still today, I keep hearing from clinicians, why don't you please use a bare metal stent because my patient has to undergo surgery? Why don't you please place a bare metal stent because my patient is a very high bleeding risk? This is no sense. Bare metal stent should be thrown in the bin. They should not exist any longer. In selected HBR patients, some studies have shown that DPT with respect to 3 months or 1 month is probably reasonable. However, these studies were a little bit inconclusive because selected patient at low bleeding, selected patient at low ischemic risk. So it's very difficult to understand the external validity of this study. Master DPT is really the first study which is showing that 1 month DPT and nothing more is the way to go, which is a very strong message. I know that there is a lot of resistance there, but this is, every time you go longer than 1 month, you should ask yourself the question why in HBR patients. That does not apply outside HBR, but in HBR patient, I think that's where we stand today. Thank you very much for your attention.
Thank you, Marco. Beautiful presentation. De conclusionar, Dr. Merino.
Congratulations and thank you for your presentation. I mean, you have and congratulations for the paper. By the way, beautiful paper if it will work. Then, I'm a little bit afraid because we are mixing 2 things here. We have 2 concerns. One is stent thrombosis, which you have shown is not a major concern anymore. It was probably. And the second concern is secondary prevention. And we have talked all to put all in the same box during this whole journey. So now, stent thrombosis with new platforms with thinner struts which produce less platelet aggregation and dural or non-dural polymers which are less pro-inflammatory is a problem that has been solved, as you have shown very nicely in your papers. And probably we will reduce our prolonged double therapy in the near future, probably in all patients. But secondary prevention, what do you think of Pegasus trial prolonging potent anti-thrombotic therapy so long, which produces so many bleeding complications?
This is a great question, and I don't think I have a great answer, but I will try to give you the answer you're looking for. You are basically asking whether in selected patients DAPT should be prolonged. I honestly would say yes, based on the evidence and based on Pegasus. And these patients are patients who are, first of all, non-HBR. You have to put outside the HBR patients, and then you have to look into those non-HBR in whom the ischemic risk is extremely high. If you do that exercise, you will find within Pegasus a mortality benefit. That's a small paper which has been published very badly because it was a post-hoc analysis. But basically, they took Pegasus that come from the TIMI group. They took the Pegasus population. They could not formally apply bleeding risk score. So they, in an arbitrary way, said, okay, let's remove the high bleeding risk patients by looking to anemia and prior bleeding. That exercise took 19% of the patient from Pegasus outside. Then you have 81% outstanding patient for the original cohort. In that outstanding cohort, the higher the number of ischemic risk, multivessel disease, CKD, number of prior PCI, the greater was the benefit for remaining on DPT forever. However, in Pegasus, the secondary prevention medication was aspirin, which is to me not contemporary anymore. The key question is, what about long-term DPT versus long-term P2Y12 inhibitor monotherapy? That has never been done. That exercise has never been done. So we don't have a formal head-to-head RCT addressing your question. We have done an arithmetical exercise to try to get there in the absence of data, which is the creation of network meta-analysis. You don't have a direct comparison, so you create networks to simulate how that comparison could be. I shortly presented the result of that network comparison at PCR, but was very quickly, nobody understood it, which is okay. We are going to present that network meta-analysis extensively at ESC. That meta-analysis, if you believe in network meta-analysis, tells you that ticagrelor monotherapy is not only at least as good as aspirin and ticagrelor, but perhaps even more effective than aspirin and ticagrelor as secondary prevention. This is a network meta-analysis. This is not coming from a direct RCT. But I think that is a reality. So I was giving the Pegasus regimen to some of my patients. Now I don't do that any longer. If I am thinking about the Pegasus regimen, I am giving ticagrelor monotherapy to my patients.
It's a very provocative approach.
Yeah, I agree. I know.
This is the same for us. We prefer your approach. ¿Preguntas? Maybe we could follow with the second presentation. La segunda parte que Marco nos trae es lo que al principio, la nueva técnica que hay de tratamiento del paciente con infarto. Durante mucho tiempo hemos quedado un poco detenidos con eso. We have stopped for a lot the efficacy and the efficiency of thrombectomy. Ahora tenemos una nueva técnica de trombectomía que parece poco probablemente para quien no es un hemodinamista, pero para nosotros probablemente luchar contra el trombo es lo más importante. So, Marco is going to present us the news about that.
Can I do a comment before Marco started the new presentation with the answer to the colleague? I must do a comment because consider two main factors. The first one is the ischemic events are more frequent than bleeding events. This is one factor. Overall, in randomized trial, ischemic event, the number of ischemic events are more than bleeding events. This is a fact. The second one is that with an individualized management of therapy, we must do better, we must perform better than a randomized trial. Because in a randomized trial, patient can do one strategy or the other strategy. But you can choose your strategy for the patient. So the result of our real life should be better, should perform better than a randomized clinical trial. So there is no answer, in my opinion, to your question, because you must choose the right strategy, and there is no data, no network analysis or other data showing the answer. I'm not talking about scores. No, I'm talking randomized trial and philosophy.
There's no specific way to go. The general answer is a very nice approach. We have to follow and produce papers on this direction, which we don't have.
Papers, I mean, science.
But what you're telling is not also dangerous. Think carefully what you said. You have killed evidence-based medicine with your statement. Because you say, in my single individual patient, I don't follow the study, but I do what I want because I know this patient, and this patient does not belong to that study. At the end of the day, you will always treat one patient at a time. So that means that you will never follow the evidence. You will never follow one single RCT. So it's dangerous what you said. Think about it.
It's an approach. It's an approach to integrate the
But
randomized trial.
then you are transitioning from evidence to opinion medicine. You are going back 20, 30, 40 years. My opinion, I think I'm right, I'm going to do it. So you have to compromise a bit in life. That's what I'm telling you.
You have to remember that Yusuf says that statistics are the most important way to make a complete lie to turn into a complete truth. So you have to be aware of statistics also. No?
And also, important aphorism was, without data, you're just another person with an opinion. So be careful again, because your opinion is important, but I think data is more important than our opinion. So what I told you before is, I think the present of antithrombotic, at least the way I see it. This is not the present, to be very honest. Perhaps it's going to be the future, but I do not know. I'm simply got excited about this new possibility of managing an issue that has been there forever in the cath lab, which is how to manage patients with large thrombus burden. And so far, whatever we did, we have failed. Basically, now we go the balloon and we place a stent in the thrombus. That's what we do, which makes sense, and that's what we do every day. So the topic is going to be stent retrievers, which for cardiologists is a completely new kid in the block. First of all, don't be fooled by the name. These are not devices which are supposed to retrieve a stent. These are simply stents which are supposed to retrieve the thrombus, which is confusing. Stent retriever is self-expanding nitinol stents, which are shown here, various configurations, various types of, which is attached to a push wire. That's very important because these will never be left in place. They are just expanded and then withdrawn. Which are meant to capture the thrombus and facilitate the removal. Now, they come into different configurations. The solitaire has been the first one to be tested. And you see, this is really stent-like. Actually, that's a stent, which is simply open at the bottom. And then you have all other various configurations. For us, that's a new thing. For the neuroradiologist, that's the everyday clinical life. This is basically what is being used routinely to treat stroke patients. And in fact, in their guidelines, they have 1A, which is the maximum level of accommodation they could have, for stent retriever. Look, they speak about stent retriever. They don't speak about PCI or going there with the balloon. They speak about stent retriever. Because before stent retriever, mechanical thrombectomy failed. Hemolysis was the winner. When they start using the stent retriever, then mechanical thrombectomy became more important than thrombolysis. So this device was a game changer for them. For us, this is completely different. Until now, we actually had case reports or maximum small case series. The biggest one is from Paul Ong from Singapore on solitaire on 8 cases. Now, we reported this year the first in-human study with one of the stent retriever which is available in the market. Don't ask me why this one. I can tell you thereafter. But we had reported the biggest case series. And importantly, thanks to this case series, now this stent is CE marked for coronary intervention, which is extremely important for us because to you a device CE mark, it's a story. Yes, it's a tough story. I had this idea many years ago when I was in Italy. I knew that the situation would not allow me to use that device in an off-label way. Switzerland is a very more protective environment, and I'm using the device since I am in Switzerland. I'm very happy that now they CE mark, so everybody now can use the device. Now, this device is slightly different than the solitaire because it's been engineered in a different way than a classical stent. At least For coronary intervention, we have no data, but for stroke intervention, the first pass success, so basically the recanalization rate after one single retriever, is higher with this stent than other comparators. Whether this is the case in coronary, I do not know. I had my experience with the solitaire at the beginning, and then with this one, I have the feeling this one may be better, but this is just a gut feeling. Now, this stent is peculiar because it has a proximal part, which is a conus-like part, which is called flow restoration zone. This one is the part that should be open at the entry of the occlusion, and that allows immediate restoration of flow. Then you have this drop zone, which are basically acting as clot pockets. They are purposely set at 90 degrees apart, so that basically they can cover the 360 degrees, and that's where 90% of the cases the clot can be found upon retrieval. And then you have the distal part, which again, unlike solitaire, is closed. So if you have an embolization during the retrieval maneuver, the thrombus will stay within the stent. I realize it's very technical, so I'm going to go perhaps be quicker through the technical thing. They need to be delivered with microcatheter, which is not the one we are used to using, the bigger one. These are peripheral intervention microcatheter. And this is our case experience. We published 61 cases, 2 sites, majority of cases done by me, I have to say. We ask an independent core lab to look into the cases, because otherwise we cannot judge our own results. That's a bit self-fulfilling prophecy story. The most frequently device was 4537, which basically tells you already an important message. These devices are massively oversized for coronary intervention. We found macroscopic thrombus in the stent, such as in this image, in 53% of the cases, and the majority one passage was enough. Immediate reperfusion was achieved in 85% of the cases. Now, we have not seen a single case of complication. The only thing which is quite frequent, though, is coronary spasm, and that's also described for a neuroradiologist. 23% you have some coronary spasm after retrieval, which is absolutely reversible after nitrates or a bit of waiting. No single case of dissection, which was actually my concern at the beginning. We have modified a bit the technique. We are not using the device as our neuroradiologist, because we are intervening upon a coronary plaque, not a stroke situation, which is completely different. That 99% is embolic stroke. For us, embolic stroke is 5 to 10%. In the majority of cases, we have a plaque rupture with thrombus. So once the thrombus is extracted, you still need to place a stent in some cases. So basically, you go there with the wire, you go there and then you leave it in place. That's the parallel wire. You don't touch it any longer. Then you go there with the second wire, upon which you deliver your microcatheter. Then the wire is withdrawn. You deliver your microcatheter, you deliver the stent retriever inside the microcatheter. Then you open it up. And at this moment, you should have already coronary flow with the thrombus entrapped in the stent retriever. Then you go inside with the guiding catheter extension, through which you aspirate while you are retrieving the stent inside the guiding catheter. How do you aspirate? In a very simple way, you use 3 60 ml vac lock syringes. These are creating vacuum. You open the lock here, and while retrieving, they basically suck blood out, which is basically a way of protecting from distal embolization. Why did we develop that complex and sophisticated technique? Well, because after some cases of using the stent retriever without aspiration, we had the first complication. And that's actually a case I did myself. Was many years ago. That's in German. I apologize for this, but that was done in Bern. So that's a massive thrombotic material in the first marginal branch. This is actually a patient who received cardiac surgery the day before. Then he developed ST segment elevation laterally, so I was the guy on call, poor me, and I went there, and that's the situation I found. So then I used the technique. This is the tip of the microcatheter in place. This is the stent retriever being opened up in the thrombotic material. And this is the thrombotic material disappearing for the first marginal branch. Look carefully into the angiogram. The thrombotic material now is here. So I open one branch and I close the other one. Then, of course, that was reversible. I basically did the same story in the circumflex. And this time, for the first time, I used the guiding catheter extension, because I said, now I don't want the thrombotic material to go back into my first marginal branch. So I protected the marginal branch and I retrieved the stent retriever inside the guiding catheter extension to avoid lateral embolization. And that was actually successful at the end. After 2 passages, I managed to have both vessels open at the same time, which was more or less the goal of the procedure. Then, of course, we went back to some bench modeling, because guiding catheter extension are used by interventional cardiologists to increase the backup. So basically to deliver things where you cannot, not to aspirate. So we create a model where we analyze whether this configuration was allowing us to aspirate from ear and not from ear. And the answer is yes. I don't go into the detail. And also we realize that 3 syringes is better than 1, not because of the higher flow rate or pressure rate, but because of duration of aspiration. 3 syringes are allowing you to withdraw the story very, very slowly. So you have a very prolonged aspiration. That's the only reason why you need to have 3 syringes. And now I'm going to show you the reason why you probably would be wise to leave 1 wire. This is one of my first cases I did. So RCA is occluded. I go there with the wire. Then I, using the same wire to deliver the stent retriever. This is a solitaire that you see here. You see that the angiographic images is different. And then, you see already here, I do an angiogram with the stent retriever in place. You have flow, as always, very good. Then you have something also going on here, though. You see this dissection, which I did not notice, to be honest. I withdraw everything. I was very happy. My thrombotic material out, but the vessel was closed. And it was a proximal dissection of the guiding catheter. And then, of course, I said, okay, now I'm in trouble. Now I'm going to go with the wire, and it was in the false lumen. Then I had to change the guiding catheter to have a different angulation, a lot of manipulation of the wire, and finally I fixed it. But then I said, look, next time I'm going to leave 1 wire in place. And I think it would be very wise. Because again, unlike the stroke intervention, we have to go back to the vessel every time after a thrombus. So it's probably wiser to do so. But of course, that is open for discussion. And this is how the technique now looks like today. That's a mid-LAD occlusion. You go there with the wire. Then you go there with a microcatheter, which is this one. You see the tip. You open. I went too quickly, sorry. You open at this stage. How can I do now? Here. No, that doesn't go. Okay. You open the stent retriever. And then you take everything back with the guiding catheter distally. And then what you get? And this is a quite interesting case because actually what we did, we used the wire that we put. We used the wire that we use to. No, okay, I have to do this. Yes. We used basically the first wire to deliver an OCT catheter. So we were able to do an OCT meanwhile the stent retriever was placed distally. And that is what we show, basically, that there was only a plaque and no thrombus anymore. And that's why we went there with the stent, direct stent, because sometimes angiographically to see whether that's a plaque of a residual thrombus is very difficult. OCT can perhaps help there. That's another case that is a subacute MI, a lot of thrombus. We did 2 pullback of the stent, and that's what we got. So the amount of thrombus you take out is very impressive. Another case, vessel is open, but a lot of thrombus here. If you go there with the balloon, it will be disaster. The only way probably would be to direct stent this one. But if you take it out, it's better, and that's what we did. And that's basically what we got out of it. And that's why now we are running the nature study, because of course we need to prove, not just showing nice cases, we need to prove that it's more effective than standard of care. And that's a case I did 2 weeks ago. I'm going to present this case because that's a very exceptional case. That's a patient with anterior STEMI who has also clear ectasia, aneurysm of the LAD. So when you see this, you know that you will have a huge amount of thrombus. That was more or less my face when I saw this case. But then I was lucky because the patient has been randomized into the interventional arm of the study. So this patient was randomized into the nature study. That was after wiring. Then this is after deploying the stent retriever. This is after first time retrieving the stent retriever. No good. This is second time after stent retriever. Then you see why the vessel was occluded, because you have a huge amount of thrombus here. The second time, though, we managed again for the second time to retrieve thrombus, and that is the vessel at the end. At the end, we did OCT because I was asking myself, should I put a stent, yes or no? If you have the patient to look into the full pullback, you will see here that there is a small plaque which is not critical and is not ruptured. So actually decided not even to stent the patient, and that is the final results without any additional stenting. Was only 2 retrieval of the stent, no additional stenting, and this is the amount of thrombus we took out the 2 times. It was very impressive, and even during aspiration, you see the amount of thrombus that we had. So I do not know whether that will be the future, but it's a very exciting device. That's the only thing I would like to tell you. Thank you very much for your attention.
Los intervencistas, sí. Me imaginaba que...
Sorry, that's me again. Well, it seems you want to make us think over the weekend, right? Yeah, good. Very nice pictures, by the way. Do you increase your thrombotic regimen during these procedures? More heparin, more something, or just the same as usual? Anti-thrombotic therapy. Yeah.
Because I was a big fan of GPI. And GPI would, in that scenario, give you more than I think.
I do agree. No, I mean. The question is directed to the after, not before, of course. Once you have taken the clot, that you let a full amount of a sea of thrombin receptors there, just willing to close the vessel again. So does this need more anti-thrombin, anti-something?
I don't think so, to be honest, because after you place a stent, you have a tonic material into the body. And the risk of acute stent thrombosis if you have no antithrombotic in place is not low. I do not think that you need to be more important if you have not placed a stent.
Thank you. No.
That's a completely different topic, but I'm trying to walk away from stent more and more. Now I'm trying to use a lot of drug called balloons, and I'm realizing that we have been practicing in the last 20 years being afraid of whatever small dissection you left in. The reality is that you may leave a lot of dissection the vessel does not get closed. So I'm not using anything more than aspirin and calado.
Were you trained in the pre-stent era or an after-stent era?
I think that the stent era is going to be...
But were you trained before or after?
No, in the stent era.
I was trained before, so we left many dissections, nothing happened, yeah.
I was training in the stent era already. And I think that all these stents that we leave in place behind is not long term. Acute term, there is no discussion. But long term, it's a different story. So
Right.
I have another question. Excellent presentation, thank you. Between 4 and 6.
That was my concern about one when I started using this stent retriever. So this lever, the smallest you have is 4.0, then you have 4.5 and 6. So in the LED, the horrible LED I showed, I use a 6 millimeter, for example. So I oversizing that stent a lot. On average, in the study by QCA, so not coming by my eyes, but QCA by 60%. I can tell you that I use 4.5 stent in vessels which were as small as 1.1, 1.2 millimeter. And nothing happened. So I am not worried. 1.1, 1.2.
What do you mean nothing happens and no dissections angiographically, but with intracoronary imaging? You find
You have micro dissection that angiographically you cannot see. I'm doing almost routinely OCT after pullback, and I have never seen a dissection of this stent. You have to, for us it's difficult to understand because we are used to coronary stent. You need to have once the stent in your hands, and then you will understand. It's extremely flexible. It's extremely flexible. It's a different stent. It's not the stent you're using. It's not cobalt chrome. That's what. It's a different stent.
Only a comment about when in ST elevation myocardial infarction, yes, I use cannula, but I use a GPI in a bailout or massive thrombosis in the intracoronary administration, with the intracoronary administration, and more frequently I use rheolytic thrombectomy. So I integrate the drug, cannula, with thrombectomy, rheolytic thrombectomy. So we can avoid the use almost routinely of GPI inhibitors.
Okay, so just a practical question. I would like to know, you know, we are very fan of any thrombectomy in ST elevation myocardial infarction. I would like to know you in how many cases of ST you use thrombectomy. Is this a default strategy or in selected cases? And considering that you have such a large experience with this device, which is the indication, angiographic indication in which you may benefit of using this device? Or it depends on the containing thrombosis, if it's a very favorable thrombo or a subacute thrombosis?
Thank you very much for these two important questions. What I can tell you that the higher the greater the burden, the thrombotic burden, the greater will be the effectiveness of the stent. I had cases where I was disappointed myself because you use the stent, which is actually very expensive, and then you don't get anything out of it. And those are cases in which you assume there is a lot of thrombus, but in fact there is no thrombus. It's 99% plaque and then three thrombocytes coming together, making the occlusion. The difficulty is how to select the proper patient for that stent. Because as you know, angiography is very poor indicator of thrombus. Angiography is very specific. If you do see thrombus at angiography, there is thrombus 100%, but it's very poorly sensitive. So sometimes you can really miss thrombus. The ideal scenario would be you do OCT to select your cases before. OCT though, it's flow dependent. If there is no flow, OCT cannot be done. So then you could use potentially IVUS. IVUS does not detect thrombus. So in reality, I am struggling myself to really tell you which patient you should use this device up front. In the study, we had compromised by using the TIMI thrombus classification grade, and we say at least 3, with a slight modification. As you know, the class 5 is TIMI 0. TIMI 0 does not mean a lot of thrombus. So in the study, it's TIMI 0 after wire insertion. That is the modification we did. So basically, if you have some flow, you can judge whether there is or there is no thrombus, majority of cases. If you have no flow despite wiring, that could still be a lot of plaque, but at least you are enriching the probability of having a lot of thrombus. But even that classification is not ideal. I am developing with a new startup based in Paris, a very cool technology. Basically, they have placed a sensor in a wire, which is an ASI wire, so it's not a stupid wire. And basically, you go down with the wire, and then you do a pullback, and that wire can map you during your pullback how much plaque you have versus how much thrombus you have. That is being used for stroke intervention, but not yet for coronary intervention, but it will come. Regarding your last point, does the time of thrombus matter? I think not, because I am extracting both fresh thrombus and relatively old thrombus. If and when you have a true thrombotic material, meaning you are sure that's embolic, you have a PFO, you have thrombus in the LA, that device works extremely well. So I guess for red thrombus it's probably even more effective than platelet thrombus. But I'm investigating that because every time I retrieve thrombus, I send it to Munich to make analysis. So they will tell me whether it's mainly red thrombus or mainly platelet, or it's a combination of both.
I have two questions related. First question is if you feel that the amount of thrombus removed is bigger than with other thrombus aspiration devices. And the second question is if other devices have failed to show efficacy, why this device should be useful in
Two very important points, actually. I am completely with you in asking that question. But the answer is actually related. So mechanical thrombectomy is a very poor way of making antithrombosis, of making a thrombectomy, because it's completely unpredictable, and in some cases you have a lucky shot, you have the thrombotic material at the tip of your catheter. In many others you are spreading it everywhere, including distal embolization, lateral embolization, and to be honest, back in the old days, I was using manual thrombectomy routinely. I remember a few cases where I had thrombus. It's not 1 out of 2, as you see here. So the proportion of cases where you get thrombus out is 10 times higher, in my experience, probably even more than that. There is a study which is coming from Rotterdam, actually, from my PhD mentor, Patrick Serraius, which is called TROPHY, where they quantified the amount of thrombotic material you could take out with a manual thrombectomy. That was eliminated from Terumo, and they quantified it with OCT, and that was extremely poor. So I think that is the reason why the studies failed. And most importantly, because it was not very predictable success of the device. Now, this device is slightly more complicated. It's not just pulling down and up a tube, it's something more. So you need to have an expert interventional cardiologist. So the concern I have is once you transition for few experienced hands into a wide distribution of the technology, whether there will be trade-off between risks and benefit. But I am pretty sure this device will provide benefit in expert hands. It's not difficult, but it's something new that we are not used to do. Yes. You have to go with the microcatheter. You have to, so it's a little bit more complicated.
To take the expertise.
For the nature study, I am selecting centers which are doing CTO, so I'm using CTO operators because I don't want to have the non-expert interventional cardiologist 3 o'clock overnight messing it up, to be honest, yes.
Okay, thank you so much, Renan. A beautiful presentation. Interesting. Bueno, hemos llegado al final. Jefe, agradecer de nuevo al presidente, a la licenciada Catalina, por la ayuda, por el sostén para poder hacer esto, la presencia vuestra, el esfuerzo de estar aquí, a los colegas, a nuestros invitados que han hecho un esfuerzo también grande por atravesar mitad de Europa para estar. Nosotros queremos que sea solamente el inicio, que esto se vuelva coloquial y que sea de ayuda también para nuestros colegas que no son exactamente cardiólogos intervencionistas, pero que probablemente pueden recoger de esto algo que sea beneficioso. Porque en definitiva los pacientes no tienen solo un problema muchas veces. Así que bueno, muchas gracias. Gracias por la paciencia también. Y bueno, espero poder decir hasta el próximo año. Gracias de nuevo.